Welcome, everyone. Today I'm joined by Shawn Sherman, developer and inventor, I believe, as well, of the Square1 system. He'll be joining me today. We'll be talking a little bit about his system and that he sees more of as a framework for problem solving rather than its individual, like its own independent modality. I'll just introduce him a little bit before we get going. He is originally a Penn State graduate. He kind of started off his fitness career in personal training after he graduated. He moved to Chicago in 1997, where he opened up a studio in 1998. And the big thing he was learning at the time is he was one of the kind of first proponents of muscle activation technique, which we'll talk a little bit more about here in a little bit. In 2004, he joined the Chicago Cubs and kind of introduced muscle activation technique to them. Worked with them for 5 years, and then he'll be able to tell us a little more about that. But then he kind of got out of that space, and while he was working in his studio, he ran across Alan. If you listen to any of his other podcasts, Alan is kind of his kind of Square1, like his patient zero, where a lot of his muscle activation technique stuff wasn't really working the way that it should. And so, out of just being a good guy, he told Alan, like, listen, I don't think this is the move. But Alan and he had built up a rapport over that time that Alan was pretty adamant about continuing. So about 5 years of treatment, and nothing was really happening. He was always kind of hunched, had pain, was having all these issues. And then I believe, if I'm correct, it was on September 8th. You like, you know what? I'm just going to throw in the opposite. I'm going to do the exact opposite of what muscle activation technique, and I'll just call it Matt from now on.
Sure.
Like he decided to just kind of do the exact opposite of what that would say. And he's like, I'm just going to feed into these positions that he seems to want to go into. And the session seemed pretty much normal, pretty much the same. He said, thanks, took off. And then to your surprise, you got a call the next day. And he's like, holy crap. He's like, I feel amazing.
Yeah.
Not only that, he's like, I'm standing a few inches taller. My pain is almost gone. And I played golf today and I shot well below my best in many, many, many years. So that's kind of my overview of what I know about Shawn from just his social media posts and podcast information. Is there anything else you'd like to add?
No, thank you for having me on your program, Nate. And I fun listening to you tell the story because it's so funny. I've told that story so many times, and I forget that a lot of times it's fresh ears. So I get bored. Oh boy, they might not like the story. So it's cool to hear your version of it. Totally accurate. September 8th of 2008, and it was 5 years of trying to use MAT on Alan to really, really neutral to sometimes negative results. So yeah, you told the story beautifully. I think that's a perfect setup for. You set up the whole history of that inception moment, that impetus moment that I had that led me to now create what's now Square1. So yeah, great, fun story.
Well, my other question is so you got your bachelor's degree from Penn State, and what was your degree in?
Exercise and sports science. Now in the meantime, now call it exercise kinesiology, which sounds way cooler. I think they dropped some of the chemistry requirements. So I'm a little bit sour about that. They made it a little bit easier and it sounds cooler, but it's really, movement science, exercise science, whatever you want to call it. Yeah. Physiology, physics, all that stuff.
I had to take very, very basic chem.
Yeah.
So
I did.
I lucked out.
That is not my thing, man. Yeah.
So just so the listeners know, like my goal is just to better understand what this thing is.
Okay.
Like I see a ton of Instagram posts and it seems very ethereal. You talk a lot about like proprioceptive inputs, this kind of misaligned or kind of inappropriate perception of the brain to what the body's doing and ways to correct it. But we don't always get to see exactly what's done. We see kind of before and afters, and I've been amazed. If people haven't seen them, they should go jump on your Instagram. It is I believe it's Square1 system.
Yep. Singular. Yep. System, not S.
Single word. Square1 system. Singular. Yep. And I've seen videos where you're taking patients that have had rotator cuff repairs. 3 months out, they're locked up, and 30 minutes later, they're moving normal.
Yeah,
With,
that's the norm with what we're doing. Absolutely. Yeah. So our norm is pretty crazy compared to probably the industry norm.
agreed. So just for kind of the visitors at home, I'll give them an overview of what I understand from Square1.
I like it.
Then you can add in. And ultimately, the goal of this podcast is to let you people out there that are wondering, what am I doing?
Yeah.
How can I be better? I just keep running into these issues where I don't seem to have all of the tools that I would like to get patients better, which is the ultimate goal.
Absolutely. I love that.
So for those at home, that's kind of, I believe it's both Shawn and I's goal, both me to kind of ask some questions that other providers, both physical therapists, chiropractors, physicians, trainers may have, and really give you an idea of what this could provide to you guys in your kind of professional development.
Love it.
So from what I understand of Square1, it's very different in that it's more of an interview and assessment of the nervous system. And I like that you don't identify it as a modality. You identify it as a framework. It is a system of assessment and treatment that you can kind of mix and match with anything else that you may be aware of in your own practice to make someone feel better. And the thing that I love about it is your comparison to software hardware. I have started talking to a lot of coworkers and patients about this concept because realistically, all conservative medicine is a feedback loop. Like everything that you have, your muscles, your tendons, your ligaments, all those things, those are hardware, but they are regulated by the activation patterns and perceptions that your brain is monitoring all the time.
Agreed.
And so the way I view kind of therapy now as a whole is even manipulations. Like everyone wants to say that, oh, I'm putting things back into place. And I don't think there is not research to really support that something is being put back into place so much as it is you're providing an input to the nervous system. And the nervous system ideally says, oh, I like that, and spits out the response that you want.
Correct.
So ultimately, I see all interventions, manual interventions, exercise, scraping, manipulation, traction, all simply as inputs you're shoving into this system with the hope that it will spit out what you want, which in most people is better movement, less pain. And in your case, you say you're looking for kind of sensory gaps that are leading to compensatory patterns that you are hoping to get the brain to change. I have seen in a lot of your posts that you talk about isometrics and breathing techniques, and then they're very specific. And I also know you break up the body into left, right, up, down.
Yep.
And I know that you also say it is not reflexive performance reset or be activated. So I'd kind of love to hear more of your thoughts of kind of what I missed as how you would describe this system.
Man, it's evident that you've done your homework on me, which is really
Thanks.
absolutely. So I think what you said is great. And how I look at everything, a thought, an exercise program, any modality, electric stim, scraping, whatever. Like you said, it's an input to the system. And I think a lot of systems out there, a lot of modalities, they talk about, well, if we do this, this is what happens. But they really oftentimes don't really check their work along the way. So every modality, whether you're doing tissue work or what have you, there is a neural component to that. The thing is, a lot of times it's indirect. And what I love about our framework is, and you said it, I look at Square1 as an interview. So what we're is when you say, all right, you assess your person, you do, that first session, like, okay, let's find out where their gaps are in mobility or strength, their pain, whatever that is. Those are all outcomes. Okay. Yeah. So, and what I think a lot of modalities do, they try to work their way backwards. Now, that's not right or wrong.
In what way? In what way do you feel now like they work backwards?
I got knee pain, and it's knee pain coming down the steps. Okay. So then a lot of times, maybe I'm wrong, but I think a lot of practitioners might say, okay, coming down the steps when that knee is behind, oh, look, the quad is being stretched, there's some knee flexion or whatever. Oh, there's also dorsiflexion. So you get this information and say, look, let's work on knee mobility or ankle dorsiflexion mobility, maybe mobility qualities of the quadricep, maybe even the ability of the hamstrings to fire. And that all sounds good. It makes sense. It's logical.
Sure.
But the problem is, would it be great if you could then interview the nervous system and find out if that's what actually is what's going on with that person in real time? So just because your approach is logical and you can defend it intellectually, that doesn't matter to the person who's in front of you. You need to find out right now in real time what their nervous system can and cannot tolerate. And if the thought that you have is it actually, am I on target or not? And if you can the nervous system, you could put people in these environments and you can actually monitor whether their nervous system had an accepting, safe perception of that input, or it's kind of rejecting it and perceiving it as a threat. So I don't look at, again, I don't look at any modality out there as it's wrong or it's bad. It's just that wouldn't it be nice if you get some eyes inside the body and find out if that person's nervous system is accepting those inputs, because the nervous system drives all the tissue. So I was in the industry, we all say, yep, we all agree the nervous system is in control. We agree the nervous system is wired for efficiency. And we also talk about, we all agree that the nervous system or that the whole kinetic chain is a real concept where everything is interrelated. But I'm saying most practitioners then don't act that way in the real world. So we give it a lot of lip service. And with Square1, we don't give it lip service. We literally get to interview the nervous system and find out, does it accept that nervous system, or not even that nervous system? Does it accept that input as a threat or as safe? And if it accepts it as safe, great, green light, keep going forward. What happens when you find a red light and the brain doesn't accept that? So what we're saying is we find out what it doesn't accept in that environment that you're trying to improve, and then we tinker. We find out, is it the knee? Is it the ankle? Is it the hip? We have there's a lot of flexibility within the framework that you get to test your little theories out. And like a good scientist, you're trying to prove yourself wrong. And Square1's all about trying to prove the practitioner mind wrong, because if you can prove yourself wrong, you can make a better decision. And when you can't prove yourself wrong, you're probably headed the right way with that person who's in front of you.
Sure. And I think I've noticed that a lot with myself, especially just because I'm young in practice. Like I attach myself onto these ideas.
Yes.
Well, and I do it, and I think I've noticed it just in healthcare generally. Like as soon as a healthcare provider that's responsible for taking care of other people's well-being, like as soon as they find something that kind of works, they kind of make it a part of their personality.
Yes.
So that as soon as like it can't be challenged.
Yes.
Because if it doesn't work and it can't be challenged, it undermines your value as a person, which is a problem, because like ultimately we're all just trying to do our best.
Yes.
And it's like, so if what you're doing isn't working, like that's nothing against you. Correct. It may just be that what you are trying to do and what you feel competent doing may not be the best way to go
at that moment in time.
At that moment in time, sure.
But that person right now, it might not be okay. But the next time, now their nervous systems are ready to accept it. So that's I love how you set that up. That's great.
Sure. And that's, so we'll kind of get more into that. But I found that a lot. Like no one wants what they're doing to be wrong because they feel like it undermines everything, rather than saying that, no, what you're doing is good.
Yes.
Like what you're doing is good for a given percentage of the population at a given time.
Yes.
And the ultimate goal of the provider should be, which of all of these techniques and information that I know is best applied to this patient right now at this time.
100% agree. Yes.
And that's why it's frustrating, because people will be like, oh, manual therapy does nothing. Scraping does nothing. E-stim does nothing. Like the research just isn't behind that. It's all exercise. And I'm all about exercise. I am.
Sure.
But I think it's overly, I think it's just too general to say that one thing is best for all. The goal should be, when is that good? Not, it's not good.
Right. And I think that goes really well into this whole idea that we all have, we got some DNA from mom and dad. We have had unique experiences along the way. So we're all very unique people. But at the same time, there's also some similarities between us all. And you have to understand what the commonalities are of the human experience and what the commonalities are with how we're wired to produce movement patterns. So you need a system, you need a framework that respects the commonalities and also respects the individual nature of who's with you right now at this point in time. And our nervous system it's so dynamic, and who we are today might not be who we are tomorrow. So we need to be able to address where they are right now and assess them quickly. What are they tolerating right now? And that's what I'm looking for, is what's that person's breaking point? Because I might look at him and say, oh, look, this guy's lean. He doesn't have a big extensive injury history. Yeah, he has knee pain now or back pain. But really, if I look at him like, well, he looks pretty good, looks healthy, that's not good enough. We need to be able to find out, what can this dude tolerate right now? And just because a person can perform a bodyweight squat and it doesn't produce pain and it looks good, that is no indication if the nervous system is right now accepting that as an input or not. So we don't want to make that assumption that just because a person can perform basic patterns that it's good enough. From a tissue standpoint, that's great. But from a nervous system standpoint, it's the nervous system's talking. And if you don't have a way to interview it and have that conversation with the nervous system, you're going to miss a lot.
Sure. And that's very interesting. I listened to a podcast recently, and I forget who it was. I'll include it in the show notes for anyone who wants to listen to it. And he asked the question, he said, are we getting patients better, or are we getting them asymptomatic?
Right.
And I thought that was really interesting, because I think, again, like you said, as a PT myself, a lot of what I'm going for is, can you do what you want to do without pain?
Yep.
And it's like, and they may be able to do that for, either a short or extended period of time.
Yep.
But it's like, it would be really helpful. And this is why I wanted to talk to you. It'd be really helpful to know, like, okay, everything outwardly appears, by observing hardware, which would be range of motion, muscle and tissue quality, like joint mobility, like that would say that things are fine.
Yep.
But it's like, if we can rule out and clear any underlying issues that the brain's like, we're not accepting this, it's not our favorite, and without PT constantly superimposing a stimulus, we're going to go back.
Exactly. Because there's no, with the human body, with the nervous system, there is no such thing as maintenance. So every input that comes in the system, our brain is quickly ascertaining, is that a positive thing or a negative thing? But none of us are in a simplistic environment where there's one thing occurring. So just because a person can, do well enough on these mobility tests, strength tests, these pattern tests, that's fine. But if you can actually figure out and interview the nervous system, find out if that person's nervous system is accepting that as an input, well, then great. So I think every input is either going to have a training effect and lead you towards, the pie in the sky optimum, whatever you want to call it. I know that's a naughty word now in our industry, but are we on a path towards optimal, or are we slowly degrading neural function? And is this thing going to get sidetracked? They're good today, but is the pain going to come back in a week, a month, in 3 years? And if you aren't interviewing a nervous system, what you think is their homework and what's appropriate for them, it might not be that appropriate to the nervous system. So we don't say avoid those things, but if we can actually get the nervous system to accept those inputs, well, then absolutely, then all that homework we're giving them is actually going to have, kind of lead them to a better place, closer and closer to optimal.
Sure. No, and so I would love to talk to you a little bit about your assessment process, because, and I'll kind of tell you what I know, and you can fill in the holes for the listeners at home. I know you talk about left, right, up, down, as being kind of primary joint actions in various planes and motions. I know you talk about, I forget how many different joint actions there are. For anyone that's listening, I know that you did a little like 45-minute video outlining like an isometric routine, and you showed kind of a like daily like maintenance routine. I think it's a few years old.
Yeah. Okay. I put that on Instagram probably. Yeah.
I found it on YouTube.
Okay. Oh, okay. Good. I haven't seen it.
Yeah. And so you go through wrist flexion, wrist extension with dorsiflexion, plantar flexion.
Yeah.
Kind of.
Yeah. Awesome.
Could you say that again? It cut out.
Oh, sorry. Yeah. So it's like kind of going through like a whole isometric routine that goes over every single joint action in the body. Yeah.
Correct.
That's cool.
So kind of tell me more about that. I know your big emphasis is what happens when the foot hits the ground.
Yeah.
Could you maybe go over kind of maybe why you picked left, right, up, down, and not forward, back? That would be my first question, why there isn't forward back,
Sure.
and then kind of how those 4 directions you chose tie into the joint actions you're looking for.
Got it. Okay. So I would say that I didn't choose them. They chose me. Okay.
Fair
So
enough.
as I was developing this, um, you know, for those who don't know, I'm not sure if your audience is familiar with neuro response muscle testing as it compares with like brake testing, force production muscle testing.
Yeah. Can I interrupt you a little bit?
Absolutely.
Sure. So I should have asked that question first.
No
Like,
worries.
obviously, from what I understand, this is kind of the first of its kind to do what you're doing. Although there are other kind of processes that people are dabbling in more neurological interventions.
Absolutely.
So yeah, what are kind of the underlying like theories that you kind of based Square1 off of? So it sounds like one is neural. What did you call it?
Neuro response muscle testing.
Okay, neural response muscle testing, and what are kind of the other kind of inspiring kind of theories or
Ooh.
things that? And I know that I've never heard anyone ask you that question, which is
Yeah.
why I
No,
wanted to.
okay. That's awesome. Okay. I'm going to say when I first went down this rabbit hole,
Sure.
I've been totally ignorant. Okay.
Okay.
So I came in and I had a background in neuro response muscle testing that I learned from MAT, muscle activation techniques.
Sure.
And neuro response muscle testing, real briefly, is a lot of PTs learn brake testing. A lot of people in orthopedic surgeons know some brake testing. So you can quickly ascertain, hey, this might require us doing some imaging because you're failing these tests. That's consistent with this tissue damage or that ligament's torn or whatever.
Okay.
So neural response muscle testing came out of, as far as I understand it, out of chiropractic, out of
Okay.
what's the like a hyper niche group that was doing something called applied kinesiology. My understanding is Dr. Goodhart, and this is back 1950s, 1960s. Don't crucify me if I got the wrong
Sure.
decades. I say
Sure.
50s, 60s. I believe he spent some time in China. So I believe that applied kinesiology, from my vantage point, seems to be kind of Chinese medicine applied, kind of brought to the Western world. So what they
Okay.
did, they took these brake testing from Kendall and Kendall, and
Mm-hmm.
they kind of changed the characteristics. So instead of looking for how strong a person is and how much force they can generate, it was more these quick, low intensity forces applied to the body externally and assessing whether the nervous system could mount a response quickly. So does the nervous system respond to this load? So
Okay.
that I learned from MAT, which is really, it's an offshoot of applied kinesiology, and then another in that history was clinical kinesiology, which came after applied kinesiology. So MAT was an offshoot of those. A lot of neuro approaches out there are really offshoots of applied kinesiology, clinical kinesiology, from my estimation and my vantage point. So I learned this neuro response muscle testing. And so when I use neuro response testing, I'm not testing a specific muscle. I'm really just testing, can your nervous system mount a response real quickly? So what I'm looking for is a failed test that doesn't produce pain. So whether it's an arm test, a leg test, a torso test, I don't really care. I'm not picky. I'm
Sure.
gonna just find a fail. And
Okay.
then what I did when I started developing this, and I still use it, I wanted to know, I really want to know what happens when the foot is the ground, because I got my degree in exercise science, but nobody taught me how the body is supposed to move, which is
Okay.
crazy. And this might, if anybody's, a little bit, if people are honest, I'm going to say most movement professionals, they don't understand how the body is supposed to move. We learned all this physiology, we took this anatomy, but the rubber hits the road, the foot hits the ground. What happens? So when your right foot strikes the ground, can you tell me what happens at the T-spine and the frontal plane and the sagittal plane? I never got that as part of my education. I was looking for that stuff. I couldn't find it. So what I did
Sure.
is I would find a failed muscle test, and I'd take my client's big toe and I'd bend it down, and I'd monitor a response, either positive response. Okay, that muscle test now got, that neuro response test got solid. Like, oh, I interpreted that as, in this moment, that person's nervous system wants more of that toe flexion. I go to the
Mm.
other, I do toe flexion there, and immediately it's a fail. Like that was kind of funky. So then I go to the second toe on the right side, flexion, checked it, solid. Toe on the left side, second toe, flexion, fail. Like, holy cow, this is right versus left. So when I
Sure.
say I didn't choose right versus left. It kind of chose me. So all we're doing is monitoring responses, and we're taking these different joints into their various, three-dimensional, three-planar movements, both directions. So we have flexion, extension, the sagittal plane. We got rotation internally, externally in a transverse plane, and then the frontal plane, with the appendages, we got abduction, abduction, or adduction, or in the spine, we got side bend. So what we're looking at is in three planes, every joint in the body, how is it responding to when we load it? So when we load it, we are imitating ground reaction forces, because we can do something on the table with somebody and get a muscle fired up or relaxed, but you stand them up and it's a totally different environment. So in our assessment, everything we're doing is mimicking at a very hyper-specific joint action level what is occurring up and down to the kinetic chain when we're walking and when we're getting upright. So when we say up versus down, I'm just looking at the kinetic chain collectively, all the joints overcoming gravity, extension, abduction, external rotation, versus the opposite where we're collapsing with gravity. So we're looking at flexion, internal rotation, adduction. So there's our up or down. And then we're looking, and we say right versus left, it is kind of going forward. We're really, it's locomotion. So when I say right, I'm looking at that instance where when we're walking the gait cycle and your right leg swings forward and has impact with the ground, boom, hit freeze. And I'm going to find out how's that person's right now, how's their nervous system tolerating that throughout the whole kinetic chain when the right foot hits the ground in comparison to the left foot of the ground hits the ground. So that's what we're looking at. We're boiling everything down, up versus down, and then right versus left.
Okay. And real quick, so in PT and chiropractic, we have these things called myotomes.
Okay.
Okay. And so like if we were looking at the lower extremity or the legs, like L2 would be hip flexion, L3 would be knee extension or knee straightening, like L4 would be ankle dorsiflexion, L5 would be great toe extension, S1 would be plantar flexion.
Okay, cool.
And so like if I was doing a test on that, and then upper body, you kind of have, you've upper traps, abduction, you have elbow flexion, wrist extension, and then elbow extension, wrist flexion as you kind of go through the cervical levels.
Okay.
But so if I was to do a manual muscle test and on, let's say the bicep, I'd put it there and I'd give it a good push, kind of a progressively increased push for, anywhere between 2 and 5 seconds to kind of see how it did. And if it started to break, if it started to like go down, how much pressure it could handle. So could you kind of delineate maybe in that example, if you test elbow flexion, like you say you're applying a submaximal quick load to see how it responds. So I would sit there and, and I'll kind of get up here a little bit so you can see, like if I'm here and I'm sitting there, I'm like, hold it. And I'm giving it a push and I'm sitting there for a few seconds. Like what would you do for neural response muscle testing that would be different?
Yeah. So neural response test depends on the books you look at. I think they'll probably talk about it lasting no more than probably 1.5 seconds, maybe 2 seconds.
Okay.
Quicker than that, I probably do about a 1.5 second test.
Okay.
For most people, whether they're big, strong pro athletes or grandma just had double knee replacement, we're using very light load, meaning I'm going to estimate between 2 and 8 pounds. And it's really a matter of, can they mount a response really quick? Is it snappy? When I'm asking in my head, every test I always do, quietly in my mind, I'm like, does it grab? Does it grab?
Sure.
Not thinking, is it strong? Is it weak? All these different characteristics. Does it grab? So that's what I neural response test.
Okay, so essentially you'd have the arm here, and I'll just bring my arm up so people can see.
I'll go full flexion. So instead of being 90,
sure. Yep. So just for demonstration purposes, though, like I would sit here and I would grab it and I would give it a good push.
Yeah.
And you would be more like,
maybe a little longer than what you're displaying, but it's closer. It's akin to what you're showing. Yes, it's more like.
And you're seeing, and your big question is, does it grab?
Yes.
Like, does the nervous system immediately perceive that it's being acted on and respond in an appropriate way?
Very well said. Yes, exactly. And what's
cool
beautiful about that, I know like a lot of times neural response testing gets kind of crapped on a lot of times by people who are probably not that familiar with it, or maybe they got a bad taste in their mouth because, hey, because you failed this, here's a dozen supplements you have to be on or something like that. But what's really cool about neural response muscle testing is, even though it's subjective, it's pass fail. So what's really cool is, if you're doing neuro break testing, like you have to delineate between like 2 negative, a 2 positive, a 3 negative. There's lots of there's going to be some intertester. Maybe it's not so consistent.
Oh,
So
100%.
testing, it's pass fail. It's a little, there's skill to it, but once you get good at it, it's a pretty obvious. Yep, it either passed or it didn't pass, which I love.
Sure. No, and that makes sense to me. And I mean, I guess for people at home who may not have understood kind of the left, right, up, down, the way I'm essentially perceiving that is when the foot hits the ground. In this case, you said the right foot.
Yep.
Your question is, what is the right leg doing, or the right side of the,
like
the right whole body?
How's the whole system globally responding to the right foot striking the ground? So we're not thinking toe or foot or ankle or knee or neck. Yeah, we're thinking all of it.
Yes,
so
thinking the whole side.
Yeah, right. Yeah,
but
cross crawl. So whatever happens to the right foot has happened in the left hand. So it's this contralateral type stuff. But yeah.
Okay. Okay. So essentially you're taking that moment, you freeze time, you look at the body. What is the right side doing? And alternatively, what is the left side doing to oppose and balance out that pattern?
Yeah.
And so that's your left, right. And then your up down is essentially saying what is happening to keep the body upright versus the forces that are, because of this interaction, are wanting it to collapse.
Yeah, and it's not so much what they're doing. Our framework, we kind of have an idea of what it should be doing, but it's more up versus down. Right now, generally, it's going to, on most everybody, and there's some slight exceptions, for the most part, all of us right now, we have a preference to either go up or down.
Okay, and what does that mean?
Okay, so the nervous system is wired. If we were to imitate ground reaction forces, let's say with up down, looking at capitis extension, cervical extension, T-spine extension, lumbar extension, any one of them. Let's do a lumbar extension, do a neural response test, positive. Then you go and do, all right, let's check out lumbar flexion, the counter move. It's going to be, chances are it's going to be negative. So you're usually going to see one of those is going to accept it as safe, and the other one's going to be, no, it's a threat, it's negative, whatever you want to call it.
Sure. Okay, so you find that often something that is helping someone stay upright versus something that would help someone go down.
Not so much helping them stay up or down.
Oh,
I would say more is the nervous system happy with up and not happy with down, or unhappy with up or happy right now with down. So we're looking for that preference. And really what it comes down to is what I talk in terms of seesaw. So I'm looking at if I have 10 pounds on the left and 10 pounds on the right, I take 1 pound off the one side, it's going to tip. So we're really figuring out which side, where's the deficiency. So what is, what we're looking at as the positive or the negative is even not quite accurate. It's more like what's helping this person get back to more of a homeostasis where there's not a preference for up or down or right versus left. So really, if jaw extension is a negative response and jaw flexion is a positive, we're not even thinking of that jaw extension negative as a negative. That's really indicative of how they're presently compensating. So they're actually subconsciously shying towards the negative, not away from homeostasis.
Sure. And so, yeah, so that leads me into my next question, which will be about compensations, but, okay, so that makes sense. So essentially the body at all times is trying to maintain this balance.
Exactly. And it needs some help because none of us have lived a perfect existence. We all stubbed toes, ate at McDonald's, did some all-nighters, lost some girlfriends, whatever, just crap happens. And it kind of mucks up our internal wiring, you could say.
Sure. And so essentially what happens is your body at any given time is compensating in whatever way it deems best to try to find balance to how it wants to move in the world.
I agreed. Yes.
Okay.
Yes.
Okay.
If we get back to up and down, that's really consistent with what you call squatting if you want. Really, it's getting upright. It's the whole body either overcoming gravity or succumbing to gravity. And then right left is the next developmental pattern of locomotion. So we're looking at the most fundamental, mature movement patterns. So we're saying like 8, 6, 7 on up. And you can do this with younger kids as well. But we're looking at those base mature patterns of getting upright and locomotion. So getting upright has up versus down, and locomotion is right step hit, right foot in the ground versus left step hitting the ground. So we're boiling all the complexity of human movement to up versus right preference. Up versus down preference, right versus left preference.
Okay, perfect. No, that makes much more sense to me. Thank you.
Yeah. Sorry. Pull teeth to get that out of me.
It's okay. I'll grab my pliers. Um, so I know that you talk about sensory gaps that lead to these compensatory patterns. I think in the PT world, we have pretty standard compensatory patterns. Like a lot of people who are dealing with some type of shoulder neck pain have some type of, parascapular weakness, some type of rotator cuff weakness. People dealing with knee pain, they may have some quad weakness, may have some hip weakness, may have some ankle dysfunction. And there are kind of these standard patterns that kind of go up and down the chain.
Yeah.
For me to best assess how I can help someone.
Yep.
So I think I would be very appreciative, and I'm sure the listeners would be intrigued. Like, so if we could maybe go through a couple of I'm sure you see a lot of back pain.
Yep.
I'm sure you probably see, I've seen you work with a lot of athletes that have squatting issues, either depth issues, throwing issues. So I'm sure you have some type of either hip or knee or shoulder issues quite frequently.
Yes. It's usually, yes. It's either back and hip, back and knee, back and shoulder, back and neck, or some other iteration. But those are the most common things, just like I'm sure you see as well.
Sure. Yeah, sure.
Yep.
So I think if you would be cool with it, I'd love to just kind of go through maybe a few of those common ones. And it sounds like back is a huge part in everything.
Yes.
So maybe, I'd love if we could maybe, maybe take the next number of minutes and go through maybe like a back shoulder general example.
Yeah.
Kind of carry it through what you would do. Cause I don't want people listening to this and being like, oh, this guy's just gimmicky. Like, I want people to have an idea of what you offer, because I think you offer a lot.
Yeah, thank you.
And I'd like to kind of go through how you would assess a number of these things.
I love it.
And maybe the things you would pick out, they're sitting there telling you your problems and you're like, ding, ding, ding. And I'd like to go kind of through your process, the patterns you identify, and maybe compare and contrast those with what I know at this point, which for anyone listening who knows more than me, which could be many of you, I only know what I know. So I'll do what I can to represent the kind of PT Chiro kind of healthcare side.
I love it.
And I'd like to be able to go through that just because I'm curious as well, like what the difference is.
Yeah.
So yeah, whatever one you want to start with, either back shoulder, back hip, or back knee.
Yeah, let's say someone comes in with back pain and hip pain. It's real common.
Sure.
So I would say the goal with the Square1 session is probably different than the goal with the big picture PT chiropractic strength coach. We all want everybody to run faster, jump higher, have less pain, get on off the floor with the grandkids. So we all have the same general. We want better outcomes.
Sure. The outcomes are the same.
Yes. So I think we have a different perspective in that I'm not going to go down the rabbit hole of back pain, even if someone comes in with back pain. So I'm paying attention to it, and I know they're coming in. That's what they want. But what I want to do is I want to clean up the whole neurology that undergirds all the neuromuscular, all these link tension relationships. And instead of thinking, oh, muscle tightness and weakness as problems, those are just downstream symptoms of neurological dysregulation is how I see it. So I'm paying attention that they got back pain, and I want to be considerate of why they're here to see me. So I might say, hey, could you, don't torture yourself, but maybe verbally tell me what are movements, what are postures, what are activities that really provoke your back pain. So I'll let them tell me. Okay, cool. All right, now I might do some general, can you touch your toes? Can you bend backwards? Just have them move and say, I want you to be a big sissy. I want you to over-report what you're feeling. Let's be careful here. Let's be conservative. And I just want to monitor, find some stuff that they can't do or maybe produces pain. I'll write them down so we can look at it later. So just establish that baseline. And then I get busy trying to restore that homeostasis where there is no preference of the nervous system to choose up versus down, right versus left. So we're not trying to get them out of back pain. I'm trying to get their nervous system where it will tolerate activities of daily living that they need to do. So what I'll do is I'll assess them, like more like the baseline. There's some mobility stuff, some pain producing patterns. I said, we wrote those down. And then right away, let's do a neuro response test. Okay, I found a fail. All right, man, go ahead, turn your head to the right. So they'll turn their head to the right. Solid. They'll turn their head to the left. Fail. Okay, I already know right now when they turn their head to the left, that's consistent with the right step and it's positive. Somewhere within that positive response, some joint action, an eye movement, a head position. So we're looking at visual, vestibular, and all the joint actions. There's going to be a vestibular gap, there's going to be a visual gap, and there's going to be a proprioceptive gap. And when I say proprioceptive gap, proprioception, awareness of joint position and space, axial skeleton, appendicular, doesn't matter. We just know that, all right, left head turn helps them get organized temporarily. Right head turn, right now in real time, they get disorganized. So we leave, we just don't even think about that. Right.
Can I interrupt you real quick?
Absolutely.
So I think I'm keeping up fairly well, but I think we went like 0 to 100, where a lot of people listen like, what the freak just happened?
Yeah.
So let's kind of, if we could kind of backtrack a little bit, I'll kind of ask a couple questions, fill in some of the gaps I have.
Perfect.
That I'm sure some of the people have at home. So when someone sits down, like someone comes to the clinic, like, Nate, I got back pain.
Okay.
One of the biggest questions I've got is, how long has it been going on? Okay. And is it constant? Is it intermittent? Like in kind of, in my world, it's kind of delineating, okay, so it's been going on for 6 months, or, there's always that guy who's been like, my back's been hurting since I played high school football.
Sure.
And so that could be, 20 years.
Sure.
So like, and those kind of point out different things to me. Yeah. Like, so what, like if they're sitting down and I come to you, I'm like, Shawn, man, my back hurts. And, what are things that they are saying that you are going to take differently than me? Yep. Like, I'm concerned about time. I'm concerned with consistent or intermittent. I'm concerned with, is it radiating anywhere? I'm concerned with, are there specific movements that bring it on? Yep. Like what is kind of your take on the interview portion?
Yep. Very similar. From a time perspective, if it's kind of fresh, acute, I want to know, have you seen a medical practitioner first? Because I'm not a tissue specialist. So I want to make sure that, maybe there's some damage here. It might make sense for you to go see a PT who's specialized in orthopedics or what have you. So if it's just like, I sneezed 3 weeks ago, like, all right, I'm probably not going to send them out to a doc. But if it's like, I got hit playing football, like, hopefully they've already seen a doc. So if it's acute and they've seen a tissue person and they did some orthopedic tests, I feel safe working with them. If they have potential, like I think, hey, this could be a tissue thing, I'll probably send them out before I even put my hands on them. If it's a long-term thing, great. So I'm just looking, if it's acute and they haven't seen a medical person, just for my own safety, for their safety, I'll send them out to somebody, a tissue person first. But that rarely happens. Usually they've been looked at by the time they've seen me, and they're usually kind of frustrated with the conventional stuff a lot of times before they see me. So that's how we look at the timepiece. As far as all the other symptoms, I'll ask, again, just to have a baseline so that we can go back at the end of the session or at the end of session 2, and we can look at those. How is that symptom doing? But I don't use those symptoms to dictate my assessment or my thought process very much at all. To me, just downstream noise that comes from dysregulated nervous system. And then as far as the last piece you had talked to, the pain-provoking positions. I might use that as clues to solve the case, but more than anything, I use it as a way to establish that baseline. So halfway through session 1, at the end of session 1, partway through session 2, hey, how's it doing when you go up the steps or when you tie your shoes or whatever that pain-provoking deal? But I don't use those to actually solve the case. What I use to solve the case is their nervous system's response to going right versus left, up versus down. So it's very systemic and very big picture at first.
Oh, so that's very interesting to me, because I think a lot of PTs and like in school, they're like, you need to use all this information the patients are giving you to make decisions. Yeah. And so but I can understand why you're saying that all of this pain, referred pain, this, that, or the other, if it's not from an acute trauma or something that you think is physically damaged, right, like that is just a consequence of how their nervous system has chosen to organize itself.
Almost always, not 100%. We don't have 100% test, but absolutely dead on. It's just noise. And I'm not paying attention to smoke. I want to find the fire. Like, what's causing this? So I think a lot of those things, mobility, strength, the nervous system grants us mobility. The nervous system grants us pain-free movement. So I want to get busy. Let's get the nervous system organized. And a lot of the noise just goes away on a very high percentage of people if we get the nervous system better organized.
Sure. So that's, I think that's very interesting that you're like, I'm listening to you as a courtesy, but
Yes.
really what you're telling me is things that I will eventually have you do later.
Yeah.
Once I have actually done what
Yep.
I need to do,
Yep.
and then we'll see kind of how the things you're bringing up are
Yep.
responding.
Because I'm not, I mean, not that I don't care about length tension relationships and these muscular relationships, but I kind of don't care. If we
Sure.
nervous system organized, that stuff's going to come along for the ride. It's like the nervous system muscles don't have their own little brains. Every muscle doesn't have a brain. It's controlled by the nervous system. So a muscle that's contracting all the time is not misbehaving. It's not a bad muscle. It's not a poorly functional muscle. It's evidence that there's dysregulation of the nervous system in a vast, vast, vast majority of cases.
Sure. Okay. So then moving on to the second piece, and these
Mm-hmm.
will be kind of tied together. Like, so now because really, if you're not overly concerned about how they describe their own symptoms, because you're like, I'm going to interview something that you have no real conscious control over.
Yes.
It's like,
Yeah.
because really that's what you're doing. You're like, I'm going to look at something you have no control over.
Because if their conscious perception of what was going on was reliable, wouldn't they fix themselves? Think about it. It's like, well, I've
Sure.
got these where, I was stuck in contracture. My pelvis is like really tipped up to the right or left. And they just start stretching like, dude, I already did that at home. I was all right. That can't be the answer. Like you can do it with more. Like, come on. Like it's not what we think we see isn't always the case. Like we have to, a lot of times what we were visibly seeing, it's just, wow, a complicated expression of crazy internal chaos usually. So we use it. Yep, here's our baseline. We'll take the picture. If it looks really ugly in your squat, you see me grab my phone and I'm getting the video camera out, it's a really ugly squat. It just is. Like I tell clients, I'm filming it. That means it's pretty ugly. Because most of us, whatever. It's okay. But
Sure.
if it's really ugly, I'll film it so that before and after to show them that there is that change or not. I'm going to be honest about it, if there's that change or not. But I don't say, oh, look, the knee's diving in, that tight adductors and weak hip. It might mean those things, but there's a million other scenarios that would cause that knee to dive in or provoke the pain. So instead of trying to come up with a logical story that makes sense, I want to kill the storyteller amongst the clinicians in our industry, because
Sure.
the storyteller, we start believing our own stories we come up with. And just because you can come up with a very logical story that makes sense based on their history and what I'm seeing, yeah, but there's a million other stories, and the chance that you got the story right the first time is slim to none, man. So I'd rather not I almost said screw what the person says. I'm not saying I want to be, but it's like I take it with a grain of salt,
Sure.
and it's like, what we consciously think. All right, that's fine. Build your little theory, but then interview the nervous system and find out. Oh, what I thought. Yep, I'm dead on, or am I dead wrong? And just have to have the humility, like, oh my gosh, what I thought I was going to see, I found something totally different once I start asking the nervous system questions.
Sure. And so that leads me into my next question, because you brought up, you're like, okay, well, I have them turn right, it's a positive test, or I have them turn left. And I believe I've seen you where there was a short clip where like you're putting out a guy's arm, and you're like, look left, and you push down, look right, and you push down.
Yep.
And so can you kind of run me through? So this person has back pain and hip pain.
Okay.
But you want to screen the whole nervous system and all the joint actions to see what is off.
Yep.
So
to we'll say, what's the word I'm looking for? Static balance, up versus down, or dynamic balance or locomotion, right versus left. So yes, how the nervous system's in through that vantage point of up versus down, right versus left. Yes.
Sure. So like, let's say with this person, like, can you kind of run me? And again, I know that obviously, like, if people want to learn your system, they're going to come to your class.
Sure.
But what does this, like, if you gave me kind of a little wider view of what you're doing to test, like, let's say you start at the head, like, and you're checking this, it's like, can you kind of run me through, like, so when you're checking the neck, the shoulders, the spine, what exactly are you doing? Are you having them lay down and push on them? Are they standing and doing different things and you're push, like, what are you doing?
Lying on their back, supine, they can be sitting, they can be standing, whatever they're most comfortable with. And all we're looking at when we go right versus left, to me, that's not even a neck assessment. That's a global test. When you turn your head to left, that correlates. That's one joint action from over 100 that correlate with right step. And when we turn right, that's one joint action, one piece of 100 plus joint actions that correlate with the left step. So that right versus left initially is just a broad base. Okay, there's over 200 joint actions we're looking at. And if we find there's a preference to turning left versus right, and we have a positive response and a negative response, I just cut our options down in half. So I just level the field like, okay, we're going to look at these 100 or so joint actions.
Okay. So let's say this person has back and the hip pain, and the hip pain is on the right.
Okay.
So what would constitute? And so, well, first of all, I want to highlight this because I think this could be very important. So you're saying that it does not, because when I'm testing a patient, there are some things I have to do standing. There are
Okay.
some things I have to do sitting.
Sure.
There are some things I am likely to test in prone or supine.
Okay.
Or sideline.
Yep.
So are you saying that you can test all of the joint actions that you need to in any given position?
Yeah, so it's very modifiable. So the whole time, right versus left, up versus down, again, is this what happens when the foot hits the ground. So when they're laying back and I dorsiflex their left ankle, well, that's left step. And okay, how's the nervous system respond to that? So it's very modifiable. So if if I have an older person and I don't, maybe I want to have them supine because we're having them do a squat, do a lunge, walk up and down the steps. I don't want to get them on their back, up, down, up, down. I might take with that older person. I might do their entire session while they're sitting down, and then I'll meet them where they are. If it's an athlete and we're just kind of mixing it into a workout, we'll probably do it standing. Okay, do your set, we'll check you. Hey, you're organized. Do a different exercise. Oh, it blew you up. There's this disorganization. Then we run them through square one, find the gap, which we haven't got to that yet. But yeah, so it's very modifiable whatever the person can tolerate, whatever they're most comfortable, what position they're in, we can meet them wherever they are.
Yeah, and that to me sounds like a huge. Again, and for anyone listening, I have not. This is the first time Shawn and I are meeting. Like, I have not taken any of his courses. I'm not paid to say any of these things, but that just seems like it would be so useful because I can't tell you how many times I get a patient and they come in a wheelchair, or they're they can't really move.
Yeah.
And the last thing they want to hear is, hey, can you stand up and come over here? Hey, can you roll over? Or hey, can you do this, that, or the other?
Yeah.
And so that would be incredibly helpful to be able to do a full assessment in any given position.
And the reason we can do that is because when we're loading the body, whether it's turning their head right or left, I would say that's an active load, just turning. What we're doing is mimicking the joint actions that relate to either up or down, right or left. So all we're not tricking the nervous system per se, but we're putting the nervous system in an environment where it thinks it's walking. So if I shove your foot back, your brain's like, oh, that's dorsiflexion. That's my right foot hitting the ground when I'm walking. So I get tricks a word that sounds deceptive. We're setting the conditions where the nervous system understands it to be, I'm going right, I'm going left, I'm going up, I'm going down.
Okay, great. So let's run through. Let's say you were looking at a shoulder motion.
Okay. The person has pain or
no, well, let's keep it with the hip and the back. So they have hip pain and back pain.
Okay, perfect.
And you are going to look at left versus right. Are you having them like what are you having them do? Are you having them do hip flexion? Are you having them do?
There's so many options. So right step has 100 joint actions, give or take, 99 to 103, depends how you break it down. And the opposite, left step has the same. So if someone comes in and like, oh man, I can't turn my neck, I got this neck stiffness, I'm not going to probably turn their head right or left. We could have them turn their eyes right versus left and do that a comparison. I could have them make a fist with their left hand, check the indicator test, do the right hand, do the same thing. So it's not specific this joint or that joint on the front end. So it's just generically, is there a preference to go right versus left? And once we ascertain that, then we can go down to which segment are we dealing with? T-spine, lumbar, hips, neck. So then we get a little bit more specific to the joint, and then the planar specific action that relates to that phase of locomotion, that phase of getting upright.
Yeah. So I think that's my question. So you say, you get their arm up here, their neck is hurting.
Yeah.
And you have them move their eye, look to the right, and then are you doing a neural response test on that arm?
Yep. So an eyes right is consistent with head left. So eyes right is part of right step. So if I'm walking, my head turns left, my eyes will be right in order to keep going straight forward when we walk. So eyes right is right step, eyes left is left step. So yes, correct. Eyes right, check the test. Eyes left, check the test. And most people, they're going to pass one, fail the other is real common presentation.
Okay. And so then you start moving down. You maybe do like a right rotation, left rotation with the
Nope,
same test. No,
nope,
no.
nope.
Okay.
All we're doing, big picture. We'll just say eyes right, we have a solid response. Eyes
Okay.
left, fail. So in my
Okay.
mind, I threw away temporarily. I'm not thinking left step. I'm thinking, okay, right step. There's an issue. There's going to be a joint action somewhere within right step. Eyes, head, jaw, neck, toe, elbow, anywhere. Somewhere we know there's a needle in the haystack. There's a joint action that
Mm,
nervous system right now perceives as a threat. And because of that, it's causing a person to favor the opposite pattern. So by
sure.
favoring that and overutilizing it, all those joint actions are going to have this negative response. So what we're doing is we're breaking down this solid phase and looking for the deficit within that. So we got to find out
Mm.
which joint, and then we got to find out which action.
Okay, so that makes a lot of sense to me. So it sounds like a lot of your kind of broad scale, they finish telling you all their story. You either stand them up, sit them down, wherever they're most comfortable, and you're
Yep.
starting with just like some eye movements and some neural testing
Yep.
to kind of pick a side.
Yep. Find out where they are.
Okay. And I
Yep.
also know that you bring up a lot the visual system, vestibular system, proprioceptive system.
Yep.
How so shoot, how do I get into this?
Maybe we should just stick with proprioception right now because the
Sure.
actions, that's what I'm thinking about. That's kind of
Sure.
what our presentation has been, and that's the
Sure, that's
original
fine.
Square 1. So that's kind of our flagship. That's our base, and
Okay.
that we end up having because we have these maps now, these joint action maps. That's like great for up, down, right, left. That's what
Mhm.
led me to come up with our vestibular and our visual resets. So
Ah,
maybe we don't have to, but I would suggest that maybe we stick with the joint thing for now. Maybe.
well, yeah, I mean, obviously, if you've developed this over 15 years, it's
Yeah.
hard to
Yeah.
really distill everything you know in,
Yeah.
1 to 2 hours worth of talking. So I think that's correct. So it's but that makes sense to me. Your big picture is trying to find, is it left, is it right, is it up, is it down?
Yes.
And then from there, you are trying to specify through more joint actions that you've mapped
Yep.
which of these is really the problem child that's throwing off this.
This system in this moment right now. Yes.
Sure.
Like
Okay.
right now,
So,
real time, presently, what's driving their need to compensate?
sure.
Yep.
And so once you find that, I know that you go through a series of targeted isometrics.
Yep.
Um, and I know that you also, with the developing of the vestibular and visual reset, you've
Yep.
probably added some stuff into that as well. But
Correct.
focusing on the proprioceptive side,
Sure.
so let's say you find a joint action and you're like,
Yep.
this appears to be what's causing their issue.
Yep.
What do you do? Because
Or not necessarily their issue, I would say, because we might clear that and there's no change in their pain, and that's okay because that's the downstream. So we're maybe finding the source as to why in real time right now they're compensating. So I always use the analogy of it's kind of like if someone wrote a neuromechanical history book on their own body. So it's like body keeps a score kind of like mindset. So what we're doing is right now what's causing them, what's driving their need to compensate. So we want to find that joint action. Let's just say, okay, we said eyes right was solid. We'll say, okay, right step. Oh, we found out that it was right hip flexion is the issue. So we have them either passively or actively do hip flexion. Oh, wow, failed test. That's supposed to be a positive. We would just have them perform a 2, 3, 4 second isometric into hip flexion. And then
okay.
immediately we check our work. Sorry, you had the question.
No, yeah. So, and I'm coming back to this. How
Uh-huh.
do you know? So you find the hip flexion is an issue,
Yep.
and you say you do a test and it's pass fail. What is that test?
It could be the arm test, could be a torso test. So we're not thinking muscles. All I need is a failed test. It could be an arm, a head, a leg. It doesn't matter. Picking muscle test. So when we
And
do muscle test, I'm not even thinking muscle. I'm thinking it's a neural response globally from the nervous system. So when
right,
I
right.
fail an arm test, they don't fail an arm test. They are failing. The brain can't get the signal to the arm quick enough. So it's really a neural fail, not an arm fail.
Sure. So in this case, what would be off about hip flexion that you would say
Yep.
this is the problem?
When they actively move into hip flexion or passively move into hip flexion, it causes that neural response test, that indicator test, arm, leg, whatever. So let's say do an upper trap test as an example. It
Sure.
was like say eyes right, solid. Boom, we get down to the right hip. Okay, right hip flexion should be solid, internal rotation should be solid, and adduction in this moment should be solid. I checked adduction, solid test. Checked internal rotation, solid test. Hip flexion, they just kind of brought their leg up, brought it down, boom, failed test. It tells us their nervous system did not like them moving into hip flexion at that moment.
Right. And yeah, so I'm still, I apologize. I'm
No,
still missing it. So
you
let's say
haven't.
there's,
Good. I'm
so,
trying to paint a picture for you. You're doing great, man. I love it.
oh, thank you. Because this is what I feel, this is why I wanted to talk. Cause I feel
Yeah,
like nothing I've listened to has gotten to this. And this is what I want to know.
sure.
So if you're standing up
Yep.
and you've checked adduction, you've checked internal rotation. So they're standing,
Good,
bring
good.
the knee up into hip flexion.
Yep. And then they come back down.
Okay. No, yes, I don't understand that. So they do hip flexion one time, bring it up, put it down,
Yep.
and then you push down on like an arm test.
Yes. And if it
Oh,
fails, it tells us their nervous system did not like that last activity of hip flexion. It just
okay.
tolerated adduction, it tolerated internal. Like, okay, this should be positive, should be positive. Hip flexion shouldn't throw them off. And when it does, it's like ding, ding, ding. We identify what they're compensating for in real time.
Sure. So that you essentially perform the motion and
Mm-hmm.
see what the nervous system thought about that by testing another joint action.
Yes. Which is all
Okay.
at the beginning, the process. We did an arm, we did a torso test, whatever it might be. Yes. There's flexibility within the system to choose any failed test.
Okay, so that makes sense. So it seems like a part of the assessment is neural testing to the specific joint, meaning you would
Yes.
do a quick test to hip flexion and to adduction and those things.
Yeah.
But
Yeah.
once you find that something's off,
Sorry to cut
yeah,
you off. We did hip flexion. We're not doing a muscle test on hip flexion. We're literally just say hug your knee, create that action of hip flexion, actively, passively, doesn't matter. So we're not testing it I mean, we're testing the nervous system's ability. Does it tolerate that action or not? So we're just having them perform the action, and then you test the global indicator test that we did at the beginning.
sure. And so maybe it may be a slight sidetrack. You can let me know if you feel our time is best spent elsewhere.
No worries.
So you find the joint action, then you test these global tests. What are these global tests?
Anything, any pull out any muscle testing manual. There's hundreds of them out there. It doesn't matter. We're not specific to that. I probably wouldn't do if someone comes with back pain. I'm probably not going to use oblique test or a multifidus test or a psoas test. I'd probably let's go to arm, a little bit away from their pain. So we're using let's back it up. We did an arm test, abduction, 100 degrees, full internal. They did the right side, positive, solid. Do lefty, it fails. Does it hurt? No, it doesn't hurt. Okay, I feel safe. We can use that as an indicator. Eyes right. Ooh, it got solid. Wow, check it out. That upper trap test is now passing with eyes right. Eyes left, it fails. Boom, it tells me right step is housing the problem. We got it down to hip flexion. Oh, I'm sorry, we got it down to the hip. It's not adduction because that was solid. We did internal rotation, solid. We did hip flexion, boom, it fails. And we're expecting it to be strong. It wasn't. It gets our attention. It's right now, hip flexion is where we're at with this made up person, this made up case.
Okay, so that makes a lot more sense. So essentially, you're simply picking a joint that can be tested without causing more issues.
Yes. So we
and
can't
it,
because I don't want to. What if there is tissue damage? I don't have X-ray or MRI eyeballs. So we
sure.
find a non-pain provoking failed test, and that's how we start. And then we map right versus left, get it down to specific joint actions.
Okay, that makes sense to me. So, you find the specific joint action. They do hip flexion. They pull it up to their chest. They put it back down. Fail.
Yes.
So you're finding they don't like that motion for this person that has back and hip pain.
Yep. Their subconscious system perceives it as a threat at that moment. Yes.
Sure. So how do you go about beginning to fix it?
It takes 2 seconds. Just bring their leg. If they actively perform hip flexion, so they literally just bring your leg up, hold it, 1, 2, 3, put it down, and then I go back and check our global test. So eyes right solid before, so we don't check that. Eyes left failed. As soon as they perform that hip flexion, I would say, hey, eyes left, check it. We're expecting it to be strong. If not, if it fails, hey, go back and do the hip flexion a little longer. Maybe you need to spend 3 or 4 seconds there. So just all we're doing is identifying positions of joints Later with the vestibular, we could talk about the head position or eye positions. We're finding positions of the eyes, the head, or joints that in real time are perceiving that position as a threat, as unsafe. So you perform the isometrics, show the nervous system like, hey guys, this is okay, this is safe, this is okay. Get that feedback loop going again, where the sensory, we drive motor, drives sensory, sensory drives motor. So we perform a motor output where we do the hip flexion. We're hoping that gets the nervous system, that sensory input back. The way we check if it's back is, okay, eyes right versus left should now both be positive is what our expectation is.
Okay. And so it sounds like eyes left, eyes right is a big part of reassessing.
As an example, I said we have 90, say 100 joint actions right, 100
Sure.
left. So just for our example, we talked eyes, but you could do tilt your head right, tilt your head left, elbow flexion right versus left, curl your toes right, left. So we have so many options. Because what if the person comes in, they've had like, holy cow, like every once in a while you get this person's had 19 surgeries and everything's artificial inside them. It's like, whoa. So we have so many options. So we could literally eyes right and left. Most people can perform that. So that is a common one that I will use, yes. But we
Sure.
don't have to. Just there's so many options.
Yeah. And okay, so that makes sense to me. I mean, obviously this is why you teach full day courses on this
Yeah,
stuff.
yeah. It's not
Like,
an
and then you give all of your people that attend all the coursework that you have available,
all the
because this is
online.
not,
Yeah,
yeah,
there's a
all the
lot
online
of
stuff.
materials. Yeah, absolutely. And we have like we recommend that they watch some of that stuff before the workshop, but then they
Sure.
have it for posterity's sake, for reference afterwards. And yep.
Sure. So that makes sense. And so I've heard you say this before, and we
Mm.
talked about this a little before we started recording. Like every time someone says, like, so how many sessions do you need? Especially other, healthcare providers, physical therapists, other trainers. And you
Yeah.
commonly say that you need 1 to 3 sessions to really get someone out of pain, moving better,
Yeah.
feels nervous system is more organized.
Yep.
And you always, the pause is the tension, and the pause is just palpable, where it's that they don't know how to respond,
Yeah. Right.
because because a lot of PTs, especially those that are very like, I do exercise is best.
Yeah.
Like a lot of what they're doing is they're like, we're going to need to do this for weeks on end,
Right.
or at least a given amount of time
Sure.
to create change. And then they hear you say, like, I can make this person move better, be stronger, and hurt less, pushing on them for 2 seconds, 2 or 3 seconds, and a few different things. There's this immediate apprehension.
Mm-hmm.
Kind of like what we talked about before, where people are like, that undermines everything I feel to be true.
Sure. Well,
And
because
so,
when it takes weeks to change things through exercise, we're talking about hardware. Absolutely. Tissue doesn't change instantaneously. The nervous system, the remodeling of nerves and all the different tissue, that does not happen instantaneously. But if
sure,
you can find gaps in the brain's perception of the internal and external environment, and then you fill in those sensory gaps, the software changes immediately. Our internal perception changes. I was just reading Norman Doidge's, I think it's the second book. There's The Brain That Changes Itself, and the other one's The Brain's Way of Healing, or something along those lines. And I love this one. This one area is talking about the virtual body versus the actual body. So to
okay,
me, body is like our perception of how things are. It doesn't mesh up with reality, and the more it doesn't mesh up with reality, you're going to be limited in mobility, limited in strength, you're going to have pain. But if we come in and fill these sensory gaps, and we get that virtual body, or that the body image, I don't like, body image sounds like body fat, you're
sure,
naked or something. But that virtual body, if we can close the gap between virtual and actual, change happens quick. So
sure,
yeah, if we back up to, we clear out one reason a body has to compensate, that normally doesn't change people's pain. What it is it's pulling out their history and clearing out 10 layers, 20 reasons, 50 reasons for them to compensate. So at
sure,
the end of one session, I might clear out 40 to 100 reasons they have to compensate. And then to two, now we're at 150 to 300, depends how fast we're working. But by the time we get through 200, 300, 400 reasons they have to compensate subconsciously, and their pain isn't changing, then I'm starting to think like, hey, this actually might be a tissue thing. You might need to go see a tissue specialist. So we're not
sure,
saying that someone's unhelpable after 2 or 3 sessions, but yeah, we very conservatively, 90% of people we work with are out of pain within 2 sessions. And it's
sure.
probably like 95. So I'm underselling it by saying 90. And that's a strong claim, but talk to any one of our students that have become proficient at it, and they're like, "You're underselling." I know, but if I told them it was 97, they wouldn't believe us. But
Yeah.
it's probably closer to that.
Well, and I don't, I can't say that that's not true. I believe that that could
Yeah,
very well be true simply because, like,
yeah,
you always get people like myself.
yeah.
I was in high school. I played volleyball. I ended up getting like a tendinopathy, and you know, but the question is, simply because you have a change in tissue doesn't necessarily mean the tissue is the problem.
Correct.
Because
I'm
I
not-
see
Right.
a lot of people come in and they're like, "Oh, I got shoulder pain," and everything.
Yeah.
They're like, "I've had an X-ray, I've had an MRI, everything's normal, just a little tendonitis."
Everything's normal tissue wise, but what about the motor control piece? And that's not going to show up on your images. And that's the thing is
Sure.
like how many people have like a total like disc degeneration? They do an X-ray, it's a mess, and they're asymptomatic. Like explain it. So it
Sure.
can't be well. If the tissue's damaged, you have pain. If the tissue's healthy, we don't have pain. Like that's is it 1962? Like, what are we talking about? Like, do we know more about the brain at this point than maybe what some of the old school guys might think? I mean, it's just we all live this. I mean, it's like how many of us had like these? Like you go for a run and you get this weird knee pain. You wake up the next day, it's totally fine. Like,
Sure.
well, did you damage your tissue and overnight it healed, or was it your brain's perception of what was going on?
No, sure,
Yeah,
exactly, and
yeah,
I agree, because a lot of these people, they come in healthy
yeah.
or apparently healthy,
Right.
and they're talking about shoulder pain, knee pain,
Uh,
and you're like, whether or not they have a positive imaging finding,
right.
it's like, in my mind, it's like, so all I'm saying is that it makes sense to me that if you clear out these perceptual gaps,
Right.
these issues that the brain is perceiving about that motion,
Right.
like that would seem like to me the most efficient way to help a lot of people,
It's
because
just yeah. It's
yeah,
like why
because
don't we clean up the
not everyone
brain
has
for
tissue
a lot.
damage.
Yeah, like all we're saying is why don't we just clean up the nervous system as it relates to getting up and down and walking? And those two patterns of getting up and walking are the base movement patterns. So any athletic skill, any more complicated pattern, it all boils back down to getting upright and walking. So if we can get it where the nervous system is more organized around those base patterns, theoretically and then practically, most people are going to see changes in their functional outcomes. They're going to run faster. They're going to jump higher. They're going to have less knee pain. It doesn't mean the tissue healed overnight or during that session, but we set up the conditions where the software is better organized. And then all of a sudden, all the length tension relationships throughout the whole kinetic chain get better. So I always
Mhm.
think about this analogy of, okay, run, sprint. Okay, it looks pretty good. Let's put a rock in their shoe. Now sprint and their shoulders doing weird stuff. Like I didn't crunk them in the shoulder. They're now their whole body, the whole kinetic chain is working around that deal in the foot. So that makes
Mhm.
sense to people. So how many times you have somebody like the number of times that we've had someone come in with shoulder pain and we actually just bring restoration to right, left, up, down, and the area we're working on was their knee or their hip and their shoulder pain goes away all the time. Sometimes people come in with a shoulder pain and they have dysfunction in the shoulder. But sometimes that shoulder pain that's presenting is actually just a symptom of somewhere else in the body. So I go into it like I'm just here to read the story. I'm not going to try to fit this person into, hey, the last person, we really got hip abduction better, and then they were able to rotate their neck. The next person, I'm going to do the same thing. Like, no, no, no. We're going to find out where this person, what is causing them to alter how they organize themselves to create up, down, right versus left. So it's very respectful to each person's, their own neurology.
Sure. Um, yeah, no, like that's all I can say is that it makes sense to me.
Yeah,
Like,
yeah,
because you can talk to 100 people,
yeah.
and some of, I'd say most of them at some point get some type of ache, pain, shooting, weird tingling, like this weird thing that happens a
Mm-hmm.
few minutes later or the next day it's gone, and
Yeah,
it
like
and it doesn't come back,
right. So
or maybe it does.
are we all like totally like mental basket cases? Because they used to think these people were all hypochondriac. That's like every one of us. I mean, how many people do you know that no, I've never felt pain? I'm like, really? The only time you ever felt pain is when you're in a car accident? Like that's I would say is nobody's reality. I mean, anybody who's
Sure.
lived life, been active, you get little aches and pains that rear their head and it just goes away. That's just the nervous system up regulating, down regulating, doing the best it can at that moment in time. It goes away in a couple of days. It probably means you don't have a lot of damaged tissue there. Probably, maybe you do, maybe you don't. we're saying we have tissue specialists, but now we have an opportunity to get some organization to our basic patterns, get that right, get that low hanging fruit, sets us up for all the tissue stuff. So
Sure.
I just want to make that clear to your audience. We're not saying square one and nothing else. We're saying, no, this is going to complement all the approaches that we're already doing. So we're not saying other systems are wrong or other thought processes are wrong. All I'm saying is keep your thought process intact. And then when you learn square one, you get to then test out, hey, is my thought process right at this moment for this person? If not, no worries. It's a framework. I can interview, find out where their nervous system is deficient, and we can give it what it needs. And I'm wrong all the time, and it cracks me up. It's like the older I get, the more aware I am that I'm dumber than I thought I was. But I can trust that up and down are opposites, right and left are opposites. I can trust that the nervous system only has two judgments of any input, safe or threat. There is no third input. So if we can exploit right versus left, up versus down, safe versus threat, you can do some real serious, create real serious changes with a high level of consistency and getting people running faster, jumping higher, being in less pain, be able to do more before the pain comes out. You're going to improve functional outcomes on the vast majority of people you put your hands on.
Yeah, no, sure. And I have two thoughts about that because I understand why kind of research and providers are leaning this way, but everyone talks about biopsychosocial factors of
Okay.
pain and stuff.
Yeah. Love
And
it.
in my mind, especially after learning more about what you have said about these unconscious perceptions the nervous system's having, like in my mind, like you can't say that they are having all these issues because of some biopsychosocial thing until you can clear out the things that are treatable by you.
Yes.
Like a lot of people like, oh, well, maybe this person needs to talk to like a psychologist to work through their feelings on pain and how they perceive things. And I'm not saying that's wrong. That is also a tool. That's a
Yeah.
tool.
Yes.
But it would make sense to me. It's like if I, from the PT world, it's like this is tight, that's weak. This is, hypermobile, that's hypomobile. It's like I can't say that they are dealing from like these life factors causing their pain until I rule out things that I can test and they're better.
Exactly.
And it would seem to me that your approach would complement very well with a lot of, I think, physical therapy and chiropractors and physicians understanding of the body
Yep.
to clear this stuff out before we say, oh, your
Right.
pain's in your head.
Totally. Right. Like, so here's what's great. If we go back to our imaginary case study of eyes right solid, eyes left negative, and the person has back pain, we found it was hip flexion. We cleared it out. So now we have temporary homeostasis. And this will go into the whole biopsycho, all the different elements that make up where we are, different types of triggers and different types of inputs. And our body, our nervous system cannot discern between thermal stress, chemical stress, mechanical stress, emotional stress. It just knows good or bad. It just knows threat or safe. So once we get that person, right versus left, no preference, up versus down, no preference, we then challenge the system. And I'll start with, hey, let's have them breathe through their mouth. That's going to happen. They do a hard workout, their mouth breathing. Let's have them squat. So what we do is we do activities of daily living, and then we monitor their response. And what we find when someone comes in, they have pain, everything we throw at them in that first session, it's going to wreck them. It's going to break them. So then we go back to eyes right, eyes left. Oh, now it's the opposite hip, and now it's hip extension. We feed it, get temporary homeostasis. Hey, do that squat again. So what we're doing is we're actually running them through activities that they're going to do every day. So I'm going to clear out, can they breathe well? Can they squat? Can they walk? Can they go up and down steps, in and out of chair, use the commode, whatever, basketball, can you dribble? So we're going to use inputs that they're going to do anyway, and we'll monitor their nervous system response. So when we find a pattern or an environment or a thought or an emotion that doesn't, like, the nervous system isn't like cool with, we can actually run it past them, clear it, re-expose them. Oh, it's still triggered, clear it. And we're lifting their resilience to squatting, breathing, negative thoughts, fear, something they might have to do at soccer practice, whatever. We meet them where they are. We take them through what they're going to do and just monitor their nervous system response, what the nervous system likes, what it doesn't. And instead of avoiding what it doesn't like, we use that as an opportunity to go deeper and pull out more deficiencies in their neurological history. So therefore, like you're saying, how this will fit, like, yeah. So if you're a golf pro, you might take them through a swing. If you're a PT and you're working with whatever, volleyball players that have a lot of ankle injuries or knee tendinopathies or what have you, you can then say, hey, let's go through what you're going to do in practice. So you can marry Square1 to what you're already doing as a PT who focuses on, volleyball players as an example.
Yeah. And I think that ties nicely into my next thing is, so let's say I've heard you talk in many podcasts, like you reset them, you clear everything out, you have them breathe, throws it off. Okay. You reset them, breathing, now good. Now go for a short walk around the room, throws them off.
Yep.
Reset them, walk around the room, good. Walk
Yep.
around the building, bad.
Yep.
So messes them up, reset them again.
Yep.
So my question is, do you find that if a patient has, you said you're clearing out 40 to 100 to 200 to 300 little things that are all a piece of why they compensate.
Yes.
So my question is, they start breathing and you do your global testing again, and you're like, oh man, it's bad again. Do you find that the same joints that were the ones giving issues are the ones that went bad again? Or do you find that it flip-flops to different things that you constantly have to be searching for? Because that sounds like it would be a very tedious process.
It hardly ever reverts. It's usually a whole new part of their story. But what would be is if in session 2 they came back and breathing throws them off and squatting throws them off. That would be super abnormal with what we're doing. Because if you give the brain what it's actually deficient in, and now it can actually return to more original pathways and not compensatory mechanisms. Compensation is costly. It's inefficient. It's just the best you can do with limited resources. But if we restore those resources, it doesn't actually go backwards. So it's always forward progress. So when someone comes in for session 2, I'm going to check if the breathing's okay and the squatting, and it's almost always cool. So when I like to show a person, like, hey, check it out, man. I haven't seen you in a week, but you're holding steady. So now we're just going to go higher on the rung, man. We're going to take you to crazy town. We're going to do more complicated things. So, which is really nice. And it's evidence that what we're doing, it's sticking, it's lasting.
Mm-hmm.
It makes sense, because if the nervous system is wired for efficiency and you actually fill in these gaps, these actual gaps that they are perceiving subconsciously, if you fill that, why would it go back? Why would the brain say, you know what, I'm going to go back to these compensatory mechanisms? So if you're doing any kind of neurotype interventions and you're having to redo all the time, that's evidence that you're not giving that nervous system what it needs. So for us, we hardly ever see we have to go back and redo things unless there's been some big trauma between our sessions, or maybe someone who's like really post-op, like very, they just had surgery 3, 4, 5 weeks ago. Well, there's some tissue healing. So some of those might go back in a short term. But for the most part, we don't have to revisit what we already cleared out in the previous session.
Okay. So I've got a number of questions, but I'll stick with the few that I think people are most interested in knowing.
Yep.
So let's say, first session, you look at them, you clear out 50 things. Okay. They breathe. You got to go back and find them again. Breathing's now good.
Yep.
Okay. They walking messes them up bad. Now longer walk around the building.
Yeah.
Excuse me. Longer walk around the building. Now good. What is your kind of standard point to which you're like, you know what? They're now breathing without offsetting the system, short walking without offsetting the system, and long walking without offsetting the system. Is that kind of your kind of checkpoint for session 1? And you're like, head home, or is there not really a standard?
I would say there's not a standard stopping point as far as what the activity is. People come in and they see me. If they see me as a practitioner, as a clinician, they get an hour. So on most people, we're going to clear out breathing and walking pretty quickly, like within a few minutes. So usually somewhere middle of the first session, now I'm starting to chase after kind of dialing it more customized to the person. Oh, my knee hurts when I come down, or my back hurts coming down the steps or tying my shoes. Well, then say, hey, bend over, don't torture yourself, but go to your ankle, come out of it. Oh, throw them off. Let's get them okay with that. Okay, now, once they're okay with that, now go down and touch your shoe. Okay, that threw them off. Okay, second, third exposure, it's good. Now tie your shoe. So we actually are then we kind of go back to what was provoking their pain. And frequently we can clear that stuff out. We're also like, oh my gosh, I'm tying my shoe again. Like, yeah. So we're just reopening the pathways that relate to their pain provoking positions. So that stuff usually starts happening the second half of session 1. So we usually clear out, oh my gosh, 20, 30, 40, 50 different inputs or environments or patterns in session 1. So breathing, squatting, walking up and down steps, 2 or 3, 4, 5 pain-provoking positions. I'll put them on slant boards, toes downhill, uphill, side to side. Find out, oh wow, check it out, right heel eversion. You're not even interacting well with the ground there. We'll clear that out. And then so we kind of make it a combination of generic triggers and also specific to the person. Generic meaning not like weak or cheap, but like no, the stuff we all do: breathe, squat, the stuff that's part of life. ADLs, I would say generic. So we clear out ADLs, clear out some specific stuff to them, and wow, at the end of session 1, we just cleared out like 90% of their daily activities and half of their pain provoking stuff. That's usually a pretty good start for most people. And then a lot of times they'll give me a text like 2 days later, like, hey man, I'm still feeling pretty good. In fact, I feel better than when I left there. Like, yeah, man, because now your brain isn't perceiving just simply getting out of a chair as a threat anymore, or walking around your apartment. It's no longer a threat. So we're bought you a little bit bigger of a buffer. We made you more resilient to your life. Yeah, man, I'll see you next week. We'll make further inroads. That's classically how it goes.
I know I can't be the only one listening that has this question, but obviously there's hundreds of joint actions.
Yep.
And in my mind, it would seem if any one of those things, including a thought or a feeling, could throw them off.
Yeah.
Like, I don't know, in my mind, it doesn't, like, it's, and it's because of my background.
Sure.
Because of my background, it doesn't make sense that nothing would throw them off and they would immediately feel better, since there's so many different things going on.
Sure.
Unless, this is me just thinking out loud, unless because all of the system, like the left, right, up, down, are interconnected throughout the whole system.
And I believe they are.
And they are.
I believe they are. And well, and I said, if you think back to it, like I never run out of ways to mess with somebody. We can create all kinds of complicated environments.
No, correct. But I just mean like in my head, I know there's someone listening to this and they're thinking, well, they can breathe and they're fine, and they can walk, but they're fine. But maybe they go to grab something out of the cabinet and that messes them up.
Yep. So we have to address that. My job is to prepare them for what they're going to do. My job is to prepare their neurology for what their life requires, their job, their activities, their sport, whatever they're going to do. My job is to interview them like verbally and find out what they're doing, learn about them. And then I'm like, okay, we got to prepare you for this. If you're a cross country runner, and just because you can breathe through your mouth, that doesn't mean you're going to be okay if you go do a 12-mile run. So we could do things to amp things up. Like we could do exaggerated run. We could have them sprint. We could have them jump over hurdles, exaggerate those mechanics. So if we get to the point where they can jump over a hurdle, well, going along at your marathon pace, like, well, that's a lesser deal. So we can make the system more robust. So the whole deal is like, what's the craziest stuff we can do that never puts them in a risky position to cause tissue damage? So if we can get so robust, and if breathing doesn't throw you off, like, here's the thing: if I did this on 100 people, first session, mouth breathing throws off virtually every person we ever had. So, but what if we get it where that doesn't throw you off? Like, well, if we can be resilient there, every day it just gets neurologically easier from here on out. So we're just whittling away at the stuff that could throw them off. We're never going to get through every single pattern, every single thought, every single environment in an hour with anybody. But what's cool is by the time you get through an hour or 2 or 3 on most people, you just cleared out like 93% of what their life looks like. And then, when I went to the gym and I set a PR. Well, that's a hit on the system. Maybe that might throw things off. Maybe. And we don't want people to be afraid of things, but it's just constantly just resetting the system. But the cool thing is, most people don't need it 3 times a week for months to get out of pain and stay out of pain. So we're never going to hit perfection. Like that's just not happening. We're shooting for the stars. We're going to hit the clouds.
Yeah. So, okay. So it would seem, based on kind of what you're saying, that there is a generalizability to essentially, if they can squat, if they can reach, if they can walk, a lot of these other things kind of by proxy
Mm.
get cleared by the body as well?
Yes. We've
Okay.
There's sometimes I'll even do stuff like I'll have them do 10 different things, fail, whatever, and then I'll clear out the most complicated one, and I go back. Oh, and those other 9 less complicated environments, that's no longer a threat anymore. So the first session, ADLs, pain producers, and then I would say session 2 and 3, we're going to try to take it to crazy town here a little bit. We're going to try to up the intensity, up the stress level, and if we can get your body to tolerate that, well, tomorrow when you just go to the office and you go do your spin class, like I'm going to try to make what we do together more complicated, more stressful, and get your body to tolerate it. So when you go back and do your regular life, you should tolerate it, and most people do.
Yeah. Okay. That makes a lot of sense to me. Yeah, that makes a lot of sense to me. I may have lost my train of
Right.
thought on that one.
Well, it's like the old movie. I don't know if your audience would have seen this is Spinal Tap. Have you ever seen that movie?
I haven't.
See, I think it had to be an old fart. I think you have to be like 45 or older, maybe. But in the
Maybe
movie, it's this
I'm just
fake
uncultured.
it's this fake documentary on this fake rock band, and they're like morons, and they're in the guitar store, and the guy wants to buy a amplifier, to buy a
Mhm.
speaker, and he chose the one because the dial went up to 11, and the other ones only went up to 10. Right, so he didn't get us he didn't understand what a scale is. So
Got it.
not the one that goes up to 11. So my job is to turn our sessions up to 11. So when you go back to life, that's a 9. I already prepared you for it. We together prepared their nervous system for living at 9 if we take them to 11 during our sessions.
Yeah, and I just remembered. So, oh, don't leave me. Come back. Come back. Oh, yes. Well, I think a lot of people, and myself included, I think the best providers are the ones that people don't need to see often.
Right.
Because if they're doing their job and fixing the things that can be fixed in the most efficient way,
Right.
humans should be able to live their life,
Yes.
a given amount of time. And I think for the people that are out there skeptical and they're like, well, at some point they're going to do something, they're just going to get thrown back off. And it's like, well, yeah,
Sure.
no duh, no duh, no
Right.
duh. It's
Right.
like you have a yearly physical.
Right.
Most people who have,
Yeah.
are somewhat health conscious, are doing blood
Yeah.
work at least once a year.
Yeah.
They're constantly taking some type of either multivitamin or supplement. Like
Yeah.
nothing in life is meant to be a permanent fix.
Right.
And
Totally.
and so anyone who is maybe sitting in their car or listening to this and they're like, well, it's not going to fix anything because it's just going to go out. It's like it probably will go out, but it sounds like what you're telling me, and this is on my sheet as well. It sounds like most people are not needing to come back after those initial 3 sessions very often. And it sounds like from what you've said to other podcasts, a lot of people would benefit from like either quarterly, 6-month, or annual kind of
Yeah.
check-in
Yeah.
to hit one of these sessions and see if
Yeah.
anything's out, just
Yeah.
because life itself
Yeah. It's stressful.
is stressful and
It's
variable.
the gravity machine never gets turned off. There's EMFs, there's chemicals in our food. Yeah, we're going to be inundated with these things. But yeah, most people, yep, 2-3 sessions on the front end. And it depends on their activity levels, depends on what they want to get out of their body. Like if
Mhm.
someone's a pro athlete and if we make them 0.001% better every time, well, yeah, there's probably value if you look at the return on investment of what it costs to work with me versus the paycheck that they potentially could earn. That's a
Mhm.
difference than, man, I just wanted to go do my spin classes at the YMCA 3 days a week. Like, well, yeah, we'll probably, most people would do well with 2 or 3 on the front end. And then whether it's bi-monthly or once a year, depends on, you know, how much abuse they're putting on their body and how much they're stressing their body and genetics and their diet, all that stuff comes into it. There's no protocol with this. So I'm a soft sell. When people come in, they're doing really well. They're like, well, when should I come back? I'm like, the joke always is, give me a call the day before the pain comes. Like, but when is that? Like, yeah, I don't know, man. Is that 6 weeks or is it 6 months or in 3 years? It varies, But it's funny you said back to, well, it's just to the skeptical people, well, it's just going to come back. I'm like, well, so you wouldn't buy a car that requires an oil change? Like, frick, I got to take it in for an oil change. That's a piece of crap car. Like, no, that's just part of what is required to be a responsible owner of your vehicle. I should want to buy a new car every freaking 6,000 miles or however you get your oil changes.
Yeah. Well, and so this leads me into one of my I've got a few questions and then kind of some theoretical things, and I think we'll probably be done before 2 hours.
Okay, cool.
But so obviously, with PT, a lot of people come in and they're like, "Well, what are you going to give me for homework?"
Yeah.
So what does homework look like? And I know we're primarily talking about the proprioceptive side. We haven't really hit the vestibular or the visual side. That sounds like it's a conversation for another day. But so what exactly are you giving for homework that lets these people kind of self-reset or self-test to keep them good, if that makes sense?
Yeah, it does make sense. And that's I'll try to be as brief as I can. That could be a whole big conversation.
Sure.
I would say for years, there was no homework because
Okay.
we're resetting the software. And if we get that right, the tissue follows. So it really is, hey man, just live your life. Now, if you go to the gym and you're feeling awesome, like really good, don't set a personal best in every one of your lifts, because we get that nervous system humming, really cool things can happen. So just do intelligent progression and just live your life. And then between session 1 and session 2, just be totally honest. Don't worry about my feelings. I want to hear the truth. Like, yeah, my back's a lot better. I do my bench press. This is better. But when I do lunges, I still feel it there. Okay, just write that down and we'll try to work with that next time we see you. But there is no homework because there's usually no homework because once we set it, the nervous system, we get on a more efficient we get the operating system more efficient. Everything they do is going to be on some level easier, better. So that we give them that week or two, let the tissue just naturally get accustomed to the new software, because the software is quick change. Tissue, there's a lagging period of time. It has to play catch up a little bit. But then more specifically, to teach somebody how to do neuroresponse muscle testing, that's not something you can teach somebody immediately. It's an attainable skill, but I say it's akin to riding a bicycle. Like, if you stick with it a couple days, a couple weeks, you're gonna pick it up. So muscle testing is that way. So I really am never teaching my clients how to muscle test, and then muscle test themselves. That's just fraught with all kinds of challenges. I have come up with this other little program called the Balance Fix that's now part of our 1 workshops, and that's centered around balance itself, putting people in balance compromised positions. So we found through in the clinic that this writing reflex that kicks in when we're losing our balance, it correlates pretty darn well with the failed neuroresponse test. So I sometimes teach my clients, especially the ones who are really into it, they had a good experience, they're feeling better, they're really active. I say, hey man, look, I want to see you again, but I kind of make it where you don't need me that much, but I'm in your corner when you do need me. So I'll teach them this Balance Fix deal, which basically it's this framework with over 5,000 postures. And it's not, you don't have to memorize 5,000 things. It's really, okay, what's your body doing? What head position you in? What are the eyes doing? So we teach them this framework. They can kind of self-administer, and we show them some resets they can do. So there's if we look at the vestibular system and the visual system, it's a little bit more simple than proprioception, because with proprioception, there's over 200 joint actions. When we look at the vestibular system, we're looking at 6 degrees of freedom, man. Flexion, extension, lean, turn. So the resets involved in the vestibular system are real quick. So we can give them some generic vestibular and some more generic visual resets that they can incorporate into this kind of self-identifying where they have problems with balance, which calls upon vestibular, visual, and proprioception. So when that fails, we show them some resets, and they can kind of keep the party going when they're not in the room with me. So we do teach some of our more into it clients some stuff that they can do on their own. But for most people, the short answer is there is no specific homework. But for the more astute into it clients, we can show them some stuff that they can do on their own.
Yeah, well, and really that aligns very closely to what I'm seeing at the clinic I currently work at. I currently work with a clinician who's in his 60s. He is a brilliant man. And he's one of the kind of early postdoctoral fellows in orthopedic manual therapy in the United States. And he does that a lot. Like the first time I really met him and I started to observe him in patients, and now we work together in the same clinic. He would provide interventions based on, different physical therapy theories. And I'd ask him, what are you going to give him for homework? And they would ask, what are you going to give me for homework? And he'd say, nothing.
Yeah. Good.
He would say, he's like, I want you to just go and live your life,
Yeah.
and see how your body accepts the changes I was intending to make with my interventions that are now making you
Love it.
bend around, walk
Love
around, and feel better.
That's it. Well, and I know with Square1, like it's weird is I'm not, I mean, I'm always rooting for people to be out of pain, and fortunately a very high percentage of people do, but I'm not living and dying if I get them out of pain in the first session, because that's an expected outcome. What I care, I'm bringing organization to their nervous system, and now they can go up and down steps, and they can lunge, and they can do the stuff that they're going to do on a normal daily basis, and their neurology is intact. I already know it's going to last, unless, in a car accident or something. We know that. So everything they do, just activities they live in, their normal workouts, whatever they're doing, that is all the reinforcement they need for Square1. 99% of the time, we'll say. I mean, just there really isn't a need for homework. They're going to keep living life. The gravity machine doesn't turn off. They're always going to be creating postures that they're going to do life. They're using their muscles. But now it's like, how are they using it with this new upgraded operating system? That life is the reinforcement. I would say exercise doesn't fix. Exercise reinforces. We're just saying, let's get the software upgraded. Everything you do is going to reinforce, whether it's in a good status, okay status, or a terrible status. Exercise is just going to magnify those things. So my job is like, let's get the neurology cool so that when you're making your exercise choices, it's all corrective.
Cool.
Yep.
So I guess I've just got a few kind of more theoretical questions. Fun. Because I think, and I was having this conversation with the guy I work with, and we would both be very interested, especially as PTs, to be able to like just take, let's say we came to one of your courses and you're going to check out a guy who's got shoulder pain. Like we would love to like feel joint mobility, look at these different things.
Yep.
And then kind of let you do your thing, which is not, you're not yanking on anything. You're not pushing on anything. And it would be very interesting to see how joint mobility and different strength and other metrics improved, because I think that's a big thing that a lot of PTs struggle with. They're like, okay, well, and I struggle with it as well. I'm about 150 pounds, 6 feet tall. So I'm a fairly thin guy. And I get a guy coming in here 200 pounds and he's got leg pain, hip pain, back pain. Yep. And it's like some of the things that we're taught are, it's like, hey, I'm going to pick up this leg and I'm either going to traction it or I'm going to lift it up while I kind of mobilize it, and it's like, and you know what? That leg is freaking heavy.
Right.
And it is exhausting to have to constantly be pulling and pushing and lifting and dragging. And I would be very curious to just be at one of these courses and be like, hey, I want to just kind of see what it does before treat them and see if these other things just loosen up, because that would be, oh my gosh, I cannot express to you, like my hands would just cry. They would sweat tears of joy.
Well, and we do that a lot in a lot of our workshops. There's sometimes opportunities where that happens. And I remember I did a workshop in the UK about almost 2 years ago now, and they're pushing me, and everybody was great. I mean, it was it was the best workshop I've ever had. It was like the most fun, just crazy personalities. I'm really tight with like almost everybody who's in that class. It's been a really cool thing, but they're like kind of hammering me, right? I'm trying to teach them this framework, but they're so like, no, you have to look through our glasses. Like, so after about 2 hours, like, screw it. All right, now I'm going to show you, right? It wasn't like I was feeling, it wasn't confrontational, but they're just like, oh yeah, what would you do for a shoulder? They're so looking down a rabbit hole, like, guys, you got to see the whole picture first. Like, screw it, I'm off script, and we did that. So the one student, she's an MD, she's a doc, Dr. Olivia Lessler. She's a kind of world-renowned doc. She's freaking awesome. And she had dislocated her shoulder, like I think when she was like 19 or 21. And she's like, I don't want to divulge her age, but we'll say it was almost 2 decades previously she had that issue. So because of that, she doesn't do any kind of upper body strength training because she couldn't push. It was an issue. So we got her into class, and like, okay, just doing some quick little assessments, internal, external, abduction. Hey, let's look for some limitations. And their big one was internal rotation. So then I ran the framework that I'm trying to teach these guys, and they're looking at which specific Band-Aid do you want? Like, okay, this is not a freaking protocol. This is a framework. You run the framework, you find the gaps, you fill the gaps, and watch the outcomes. So she couldn't internally rotate. This camera didn't see it, but she was like, literally, if this is neutral, I mean, she had 5-10 degrees. And dude, 6, 7, 8 minutes, boom. I mean, 90 degrees, and they're losing their minds. Like, yeah, it freaking works. But can we go back to teaching you guys a framework? It's always, not always, it's almost always going to deliver those mobility changes and strength and pain alleviation because we're getting the software better organized. That's going to happen. And when it doesn't in 10 minutes, it's okay. Like, it's like it took you 30 years to get here. It might take us 2-3 hours to clean up the software. And if what's holding you back, mobility, pain, whatever, if it's tied into compensation, this, given enough chances, it's going to resolve it. And when it doesn't, it tells us, you know what, the primary thing that's holding this person back, it might actually be tissue. It might actually be they have the world's worst nutrition. It might be that they lost a child in a car accident and they're in such distraught, loss. This isn't going to fix those things. But what's really cool is what's holding 90 to 95% of people back, athlete, non-athlete, knee pain, back pain, all these chronic, like no known etiology, like where did this stuff come from? Square1 is up to the task of like, wow, it's going to handle so many of those things. And it's going to partner well with tissue mobilizations, adjustments of your chiro, electric stim, exercise programs. To me, those are all, like, I'll use the analogy of an iPhone or, an Android, whatever. Everybody wants to know, what's the app? What's the app? Oh my God, I want to do another app. And all I'm saying is, can we get the operating system working a little bit more functionally? Can we get this thing cleaned up? If we do that, you can add the apps to that. So I look at it to frame what we're doing. I think this is an opportunity for clinicians to learn how to update the operating system as it relates to basic postures and movement patterns like locomotion. If we get that operating system, a very high percentage of people are going to have significantly decreased return to play times, accelerated recovery times, whatever you want to call it. We're just setting the stage to have more success with the interventions you're using. But we need that framework to know how to, just get organization, regulation back to the nervous system.
Yeah. So I think I'd like to just I'd like to close out talking about a few things you've brought up that you've worked with.
Yeah.
And then we'll kind of clear it out. So in about 10 minutes, we'll kind of look at rounding it up at about 2 hours. Perfect. But I'd like to run a few cases by you because I'm sure you have seen at least someone with these various diagnoses.
Okay.
And the one I was most interested in on one of your other podcasts, you said you have worked with people who have had strokes.
Yes.
That are dealing with these limitations.
Yeah.
And whether it's a limitation in strength, a limitation in movement, a limitation in balance, and even people who have had strokes, which people would consider a major trauma to the nervous system.
Right.
It's like these people are still responding with increased movement, and increased, just increased performance and function.
Yeah.
And
all that agility, everything. Yes.
But I will say, and I appreciate that you're honest about this. You have said you don't have very good luck if the stroke has been acute.
I don't think I've said that before.
Oh, okay. Yeah. Please tell me more.
I think what it is so I've only had my hands on a small number of folks that have had strokes. So we'll say less than 10. Like between myself and there's a lady, Dawn, who works with me, who's like kind of my original test dummy. I think between she and I, maybe together, we've worked on 9, 10, 11 people with strokes. And I didn't know enough going into working with people with strokes, the right questions to ask. Because there's been so far, I think I've had 2 or 3 folks that have had strokes where there was 0 changes in functional outcomes. So I just want to be totally honest. I'm not saying everybody has stroke is going to have a great result with Square1. I'm not saying that. Yeah. But those 7 or 8, it's been... a few of them have been borderline miraculous.
I was waiting to see what word you were going to choose.
Yeah, I'm like, all right, I'm going to say it. So my own mother had a stroke. It would have been, I'm losing track of time. It was either a year and a half ago or 2.5 years ago now. Long story short, I go over to my brother's house. She built a mother-in-law suite on my brother's house. I was living in Chicago at the time when it happened. I moved back to Pennsylvania. So I'm really close physically to my brother and my mother. And we go over there and he's calling me up. Like, come on, what's going on? Like, come over here. So we go over there and she's like, I think mom just had a stroke. And she's sitting in her chair on the deck and she's slunched over and she has like palsy in one hemisphere. I think it was her right hemisphere. I can't recall now. So she's slurring her words. It looks like she has about 12 beers in her. I mean, she looks like she's going down for the count. Like she's about ready to pass out. She's lucid, but her system took a hit. I said, do your stuff. I'm like, all right, yeah, let's do it. So I used like a Popliteus test. He knows it's called Square1, but just do it. Like he's stressed. I'm like, oh yeah, this is freaky deaky. So I didn't get the camera out to film this because of my mom. Like, holy crap. If I was a better business person, hey, where's my tripod? No, like she just had a stroke somewhere between an hour and 4 hours before. He had been gone somewhere between 1 in the afternoon, 4 o'clock, whatever. She had the stroke. And so I used a Popliteus test, just internal shin rotation. So she's sitting there and I'm doing a muscle test on internal shin rotation. Fails, right versus left. We found it. Boom, reset. Boom, boom, boom. What I was using as a trigger, I'm like, okay, she's slouching. Her face is slouchy. She can't speak very well. I'm like, hey, Mom, I want you to say supercalifragilisticexpialidocious. And she's like, super, blah, blah, that's all good. Okay, that's enough. Boom, it triggered her, cleared it. Okay, Mom, say it again. Then it's supercalifragil, and then it trails off. Cleared it. Third time, supercalifragilistic. She's getting further and further through this nonsensical word. And by the time we clear out 7, 10, 15 things, she's saying it. I see the palsy in her face. It goes away right before our very eyes, right? Boom. All set. Crazy, right? At first, my sister-in-law was like, what are you, like this kind of this waste? Why are you wasting time, whatever? And my mom, by the way, wouldn't go to the ER. She's like,
okay. I was gonna ask about that because I'm sure there's someone somewhere.
And this is like this. Yeah, tell her to get to the hospital. Right. We're talking. Like, Mom, we got to go to the hospital. And
hey, Shawn,
I also want to respect her wishes. She's 75.
Can you hear me? No, it must be the internet connection. The last like 30 seconds or so have cut out and your picture's a little blurry.
Okay.
I'll kind of tell you to where we were at and then you can keep going.
Yep.
One, I'm glad that you brought up that the initial thought was to go to the ER because I'm sure someone who has not, who is only listened to the last few minutes, they're like, get her to the ER, get her. And someone is just screaming, as someone's screaming at their speakers right now, listening to us talk. So I heard you say that your sister-in-law was like, we're losing time, which is a big thing when people have strokes.
For sure.
Yeah, they're like, we need to get this person to the ER now.
Yeah. So she doesn't want to go. She's like, and I kind of figured that's what she would do. But like, Mom, listen, I get it. I know that docs don't have all the answers, but holy crap, they're awesome at emergency medicine. You have a stroke, you have a car accident. Holy crap. This is where these guys get, why they get paid the big bucks. Let's go. And I couldn't convince her. Like, all right. So what am I going to do? I'm going to knock her in the head and drag her to the car. Like, I'm not going to go against her wishes. If she wants to die in her back porch after because she has a second or a third stroke, that's her choice. So I'm going to respect her wishes. But whatever. So we did it, ran Square1. Dude, she spruces up. She's able to speak. The ballsy goes away. And I'm like, Mom, can we go to the hospital now? Because, yeah, you're functionally better, but we don't know what's going on. Is there a clot floating around? Is there another one coming? And I couldn't spook her into going. So, all right, well, you're going to do your thing. Like, well, we're going to go fishing because that's what my brother and I were going to do. Couldn't talk her in. I'm not going to call the ambulance. She's not going to go out and get in. Like, I'm not going to do that. I said, Mom, while I'm gone, I want you to sing. So we're going to go fishing. We'll come back. And we're driving back. And I told my brother, like, hey, we got to be prepared. Like, Mom might be dead on the steps because there could be a second or third. We don't know. I couldn't, so we're both, this is what it is. We get there. I go to her house. I hear her. She's singing. Like, she sings great. You could never tell she had a stroke. She did go in, like, that was on a Saturday. She went in like 2 days later on a Monday. And they're like, yeah, I'm like, okay, because I think other people are like, you should go. Like, you could be going, like, there could be more strokes coming. Like, so go check it out. She went in, and they said she didn't have a stroke. Nobody would be dysfunctional if they had a stroke. Like, I'm like, don't even. And she's like, I didn't even bother trying to explain it. So I'm like, yeah, don't. I mean, they're not going to get it anyway. But so there's that. That was an acute one. That was within hours. I mean, it was crazy. Recently, on Instagram, we had a guy, Jevin Bowman, who's out in Tulsa, and he knew he had this guy coming in who had a stroke, I think 2 or 3 months earlier. And like, dude, get the camera out, film this sucker, just in case he had this great outcome. And he had really great outcome. The guy was shuffling his feet.
Oh, I saw that guy, the little short guy, and he was having a hard time getting out of the chair and having a hard time walking.
Yeah.
And then like, it's like 10 minutes of square one and suddenly he's like up and
Yeah.
cruising
I mean,
around.
was he perfect? No, but was there profound impact? Absolutely. I mean, it's pretty. I don't know how you'd grade his gait. If he was a 3 out of 10, and by the end of the session, he was like a 6 or 7 out of 10. It was like way better. So yeah, for
Yeah.
stroke,
So no,
it's pretty interesting.
yeah, that was awesome. So again, for anyone listening who hasn't, we haven't brought it up, it's like you can find Shawn at Square One System, not systems. So it's Square One System singular on Instagram. And take a look at these videos. The last.
Sorry to cut off.
Oh yeah, numerical one, not written out one.
Yep. Sorry to
Got
cut
it.
you off.
And for anyone wondering, we'll include that. Oh, you're good. We'll include that in the show notes below. The last thing I'd be really curious about, because this is, I think, a big one in PT, is frozen shoulder. Because a lot of people, I figured you were going to say that. Because a lot of people are like, the capsule of the shoulder itself, it is inflamed, it is stuck, it is locked. And, I think a lot of providers listening, unless they're familiar with different interventions than me, which I'm sure most are, it's like you go to do passive range of motion, these people are like, it's stuck. And we're really just trying to slowly kind of push through these range of motion deficits with various interventions. So why don't you tell me a little bit about that? And then we'll kind of wrap up with any final thoughts and let you enjoy your night.
I appreciate it. Yep. So frozen shoulder, I'm not going to say we get these amazing results because we generally have not. I will say I've never had a frozen shoulder where we had full resolution, whether it was 1 session, 3. I've never seen that happen. Sometimes someone will come in, maybe they're presenting, maybe they have 70 degrees of flexion. You're not quite at 90. We've had some that in that session, we get them to 130, 140. So clear cut progress, but I've never had someone come with frozen shoulder. Check it out, 180, 180. I've never seen that happen. And I would say, honestly, maybe about 1/3 of the time we have some positive, like clear progress, but not perfect. So when someone calls me and they have frozen shoulder, what I'll do is I'll look at my schedule, and if I get some time, I'll say, here's what we're going to do. Why don't you come on in? And if there's no change, I'm not even going to charge you, because if it's a true frozen shoulder, we're probably going to see no change. And I don't want to waste your time. So I'm always game to try. I said, we've had a few that there's significant improvement, but I'm going to say, again, 60, 70, 80 degrees. We've seen them get 110, 130, even 150 sometimes. Like, wow, really nice. Changes their progress, changes what they can do in a course of the day. But to say, oh my gosh, we've resolved it, I've not seen that happen yet with Square One.
Okay. So, I mean, my overview understanding at this point then is, again, you're cleaning up the nervous system.
Yep.
If there are true mechanical, physical changes, something is broken, something is stuck, you have a contracture, those things are physical changes that you shouldn't expect to work miracles, because those could still stick around even after you clear up software issues.
And like I said, that shouldn't expect, because we've got a couple crazy stories. Of like L5 vertebral fractures, and like it's like they're perfect. Like, oh, this is crazy. Like, so, and that was an D1 athlete. I say, look, talking to docs and stuff, like, look, he obviously still has a fractured back, but he's functional. Pain's gone, mobility's back, strength's back, everything's good. Played out the season with a broken back. So just because someone has broken, damaged tissue doesn't mean we can't help, because we have crazy stories. But when it's like, it's not going so well, my first thought is like, who did you see? Was this PT focus on orthopedics and try to find, like, maybe you should go see that orthopedic surgeon? Like, just, maybe you go see a sports med guy. So sometimes we get, like, when there's no satisfaction, it's, hey, when's the last time you had a physical? We have some crazy stories that people were at end stages of cancer, but they're presenting with back pain and there's no changes. And just because they don't help someone with back pain doesn't mean they have freaking back cancer. I don't want to spook people, but we've had a couple stuff where they were actually in this death throw immune deal that they didn't know that's what it was, because their only symptom was back pain. So when we don't help somebody, it's usually tissue. It's rarely, but occasionally it's some other disease state. So it's something else that's not this motor control compensatory piece.
I think for those listening, I mean, even if, whether or not you think this is a good fit for you, it sounds to me like, so that guy had a broken back. I personally couldn't recommend someone with a broken back continuing to play out the season, but
Right.
from a rehab standpoint, let's say they have a tissue dysfunction, a tendinopathy, maybe they do have a stress fracture. It's like, and if you could clear out the nervous system and that pain goes away, you can begin to load that tissue in a way that will help its healing so much better.
That's it. Exactly it. And that's the thing too. That guy with the broken back, that one obviously wasn't my call. It's a D1 program. Sure. Yeah, the PT, everybody's there when this is going on. So it was like, that's certainly not my call. But it was like, dude, that dude played Big Ten player. I mean, he was like preseason Big Ten player of the year. I mean, he was a stud, and it was crazy. I remember. Sorry to keep. I don't want to prolong this, but the one coach. Oh my gosh! He's like watching. This is so cool. He's, what's your best story? I'm like, I think you just watched it. Your dude has a broken back, and he's like, now he's totally fine. Like, this is crazy. So you might have just witnessed it. So, like, yeah, you lived it with me. So it was fun because he's like, oh, he was waiting for more stories. Like, this is crazy town, dude. This was a pretty good one. So, yeah.
Wow. So, and anything else, Shawn, that you'd like to kind of add in before I ask you kind of some final questions, some of which we talked about before the show. I'm going to ask you some kind of questions. Oh, you're cutting out. One sec. You are completely frozen. We'll see.
Okay.
You look like you're doing okay now. What were you saying?
I said I think we covered everything in quite a lot of detail. It's kind of tough. The problem with trying to verbally walk people through this, and your questions are great and super patient and allowing me to kind of fumble through like this whole process. It really, it's one of these things I tell people, like, you have to experience it, and it's good. But I just appreciate you letting me talk at length and in detail and try to lead your audience through this. I would just implore people, go check out our Instagram feed because there's so many success stories there. Some, if you dig in deep enough, we have some scoliosis MRI changes, 57-degree, I think it was 57-degree reduction of a scoliotic T-spine. I mean, just crazy stuff. Yeah, but that's not me like, oh, that's with a goniometer. It's literally MRI before and afters, like just crazy stuff. So it's like we have so much social proof on there. I just hope that it would spur the right person to ask questions, reach out. I'm just kind of pushy sales guy. I think we got something really cool. If someone wants to heighten, whatever their practice is, I just think this is in it. We haven't come across something where it doesn't sync up with very well. I just encourage people to ask questions, be curious. Assume that I am lying to you. Dig in and investigate us. I dare you. That's what I would say. Like, we're kind of an open book as best as we can be.
Yeah. Well, and what I think, like, in my opinion, there's a lot of people who want to jump in and say like, oh, that's wrong, or where's the research, or the evidence says this. And I'm, and that's all fine and dandy. Everyone has their own approach. Totally. But ultimately, like, in my opinion, you can't say that someone else is wrong until you know proficiently enough why they could be right.
Correct.
And unless you know why they could be right, you can't really refute that.
Totally.
And in this case, like, and I love that you say this, I'm of the same mindset. I've heard people be like, well, so what's the research supporting your stuff? And you're like, I don't know. I've never done any. You're like, all I know is that it works. And people are like, well, yeah, but the research. And you're like, truth be told, I don't care.
Yeah.
You're like, I'm too busy fixing people to take time off to do research. But if other people want to jump in and research what I do, you're open to that.
Yeah, we're totally open to that. It's just that I'm the chief, the cook, and the bottle washer. So, there's different groups, different universities that have reached out. We're probably at some point going to have some research. We just did a workshop at the University of Georgia. Those guys, with the basketball team, they seem open. Like, they're already doing a lot of data collection. Like, yeah, just so you know, I'd love to come back down. We'll do this. I got a text from them just yesterday. Like, hey, let's do this. Like, cool. So we don't have research, but it's like, you don't need a goniometer to see the changes. Like, go to our website and you'll see somebody who had like a rotator cuff tear repair 3 months later, 6 months later, physical therapy 3 days a week, and then 10 minutes her arms overhead. Like, why do I need research? I know what I see. She knows what she sees. It's not like we're splitting hairs like 1 degree or 3 degrees. We're talking like, you want to see 30-degree change, 90-degree change. It happens regularly with this stuff.
She's good. If you hear that lapping, it's our St. Bernard.
Oh, nice.
Daisy girl. You can probably see her. I'll kind of move the mic for a sec.
Wait,
She's a big girl.
150 is who? Do you outweigh the dog or does she outweigh you?
I outweigh her for now.
For now, what's she going to get? $170 or something?
Yeah, she'll probably be about 170. She's about 130 right now. So she's just our sweet little girl. But okay, so just some last questions.
Yep.
Okay, Daisy girl, can you not drink right now? Okay, go over there just for a minute. You can come back and get more water in a minute. So a couple things I'm going to kind of overview where people can find you. I believe it's square1system.com.
Yes.
Yep. So square1system.com. And for anyone who's looking to just kind of dip their toes in kind of the pool, there are various online courses that are available for purchase. Yep. There is the Science of Square One, which is about $35. There is Signal 6, which is, I often hear Shawn describe the total Square One as kind of a sniper rifle headshot, like you know exactly what you are fixing.
Yes.
And it seems like Signal 6 and the Self Reset are both $99, and they are more designed as a blanket, or kind of they're designed to kind of hit these kind of reinforce normal patterns. You can correct me if I'm wrong, Shawn. And then they also have the original Square One Online, which is all of their material they taught before 2020. So
before 2020, yep. And it actually is closely related to our still current level 2 now. The original version. Yep, absolutely.
Great. And so you maybe you may not be able to get out to a physical course for, it's not so much the cost of the course as it is the cost of getting to where it is, the stay, the travel, the food, like that adds up a lot. So you can get access to almost everything they're teaching on day 2 in their Square One Online for $650, which sounds like it's a steal because it provides all of the joint maps that you have.
Yeah.
And essentially all of this proprioceptive testing and clearing that we went over.
Yep. And I say that I'm always trying to be as honest and open as I can and helping people fit into the right piece. The problem with the Square One Online is learning how to do neuroresponse muscle testing through digital format.
Through a reading.
Problems. But for your audience, if you have people that are PTs, chiros, and they're already doing some muscle testing, I would think that they would acquire the skill a little easier than someone who's never experienced hands-on in their day-to-day operations with people. And I would say the Science of Square One, that's just a piece that we have all of our live workshop people check out. There's nothing practical about it. It's just kind of like neurology 101 through a Square One lens. But if people are just like, I'm just interested in the overall overarching premise, that would be a good piece. But there's nothing really practical in there that you would use in a clinic the next day or anything.
Okay. So it sounds like the Science of Square One is more theory-based, not practical. Yep. Signal 6 is more group-based, not specific.
Yep. Or warm-up. Yep.
Okay. The Self Reset is more, I'm buying this for myself at home.
Yep. So we teach one muscle test. It's a little bit of a problem to test yourself. It's a little tough, but it really is. It's a veiled version of our vestibular reset.
Okay, got it.
Yep.
And then Square One Online is essentially everything you would learn on day 2. That really is
level 2, because we now are
level 2. Sorry, level 2.
Yep.
So everything you're going to learn. Oh, sorry.
So and that is the original version. That's what got the whole Square One thing going. Is in that Square One Online. Yep.
Okay, got it. And just so you're aware, listeners, like that it's going to give you everything you would learn at the level 2. But, there's going to be a barrier to entry. The fact that you're only reading and you're not going to get the experience of working with Shawn and his team.
Yep.
So just a couple last questions, Shawn. You're welcome to say, I don't really care to answer that one. I'm fine with that. Cool. If anyone is interested in seeing you, let's say they are either a provider or a patient, I believe your clinic is in Chicago.
Yep. I'm in the suburbs in Western Springs. It's called Western Springs. It's the western suburbs of Chicago. I'm usually there on Mondays and Tuesdays, and I live in central Pennsylvania. So occasionally people fly to central Pennsylvania in the middle of nowhere, and they come and see me at my home sometimes as well as clients.
Okay. And is your studio's name and address on the website?
The studio name. Yeah. The address. Yes. Yep.
Okay, good. So you guys can find all that at Square One. And in case people are interested, one, as a practitioner to provide it, or two, as a patient to receive it,
Mm-hmm.
what's kind of the range of costs to see either you or someone who is certified in
Sure.
this thing?
Yep. So my current cost, if someone were to come see me personally, we do. What do I think here?
Because I
There's,
know you generally sell 3 package
yes.
session, like a 3 session package
Yes.
that's available for like a year.
It was 3. We went down to 2 because I don't want to sell more than people need. So I sell a 2 session package in Western Springs for $475. When
Okay.
people fly from out of town, sometimes we'll say, "Hey, look, we should get you in the books for 4 hours, and if we don't need the last 2 hours, no big deal. But if we do follow up, it's basically it's 175 for any follow up. So you're gonna spend 475 to 650 to come see me for 2 or 3. Our practitioners, you can find a Square1 Movement Pro on our website. That price range could mostly somewhere between probably 100 to 200 per session, where most of our practitioners would probably cover 99% of our practitioners.
Okay. Awesome. Yeah. So
Yep.
if you're someone who's looking to expand your skills, and really, I can't emphasize it enough. I have looked at a lot of people. It's kind of my addiction is I just look for different people, what they do and how I can learn from them. And I have not found anything like Square1. So, for if there's people out there that are, wondering what can I do to set myself apart? Shawn
Yeah.
often says, Shawn's big thing is becoming irreplaceable. It may be something that you should look into getting credentialed. And I believe in order to be a credentialed Square1 provider, is it just level 1 and level 2?
Right now, currently,
Or
level 2, level 1's 2 days, level 2 is 2 days. At this point, by attending level 1, you're considered certified in level 1. At
okay,
soon have we used to have like a little bit more stringent where people take a written and a practical exam, but as it kind of expanded, it's like, oh boy, we have to rethink. We're probably gonna have some entry. Some barriers to entry where people are going to pass an exam before we let them into level 2. Just we don't want to waste their time. We want to make sure people are ready for level 2 because there's a lot of information at level 2 for 2 days.
sure. So if someone jumps on the website and finds a Square1 Pro, you can confidently say that that person has done level 1, level 2, and has in some way been vetted by you or the better trained members of your group.
Lightly vetted at this point, but we're going to raise the
Fair
bar.
enough.
But honestly, everybody who I think is listed, they're all there's a certain level of proficiency just from being in the room with them. We know that they're okay, but we're going to
Sure.
make quality control.
Yeah.
But there's nobody on there. I'm saying to avoid this person. There's nobody like that, so I'm not too worried that. But when we start having 5,000 people, it could get out of hand. We know we have to have a quality control as it grows.
Sure. So again, for anyone listening, like if you look at that pros list, there's probably about 30 pros on that list. I'm sure it will grow.
Yep.
But the Western United States is a big area of opportunity. Like in Colorado, there isn't one.
Right.
I am,
now.
I am hoping to potentially become one, given that I'm, located at the location of the Olympic Training Center and where all these international teams come to be.
Right.
So
I mean, how fit Colorado is, like, this is a perfect, fit for that state for sure. I mean, it's great.
Agreed. So I think so. Just recap, guys. He's got multiple courses available. You can contact either a Movement Pro or his group in order to kind of know more about it or join a course. And I just hope you can understand from this conversation that it's meant to add on to what you already know and help you better understand what is true about what you know, so that you can provide better care to patients. Shawn, any last words?
No, man, I'm just extremely appreciative that you opened up your audience, an opportunity for me to come and talk to your audience and give me this platform. And I'm just grateful for that. And you trying to help me spread the word and your curiosity and your tenacity to track me down and find me. I'm glad we did this. So thank you very much to you and the listeners who've listened to this whole thing. So thank you, everybody who's listening.
Yeah. So thanks, everybody. Take care. We'll see you next time.